Very good evening, everybody. I want whomsoever present to acknowledge faster. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. I want whomsoever present to acknowledge faster. I want whomsoever present to acknowledge faster. If you could able to hear my voice and see the screen properly, type yes on the chat box. Type S on the chat box if you could hear my voice and see the screen properly. Okay, much better. So very sorry for the late night session today. So today we are going to talk about the obstetrics. So speaking about the obstetrics, what are the things we are going to talk here, people? So as per the obstetrics and gynecology, you know what the high yield areas are. Number one is your diagnosis and physiological changes in pregnancy. Diagnosis and physiological changes in pregnancy. The high yield areas. The high yield areas are diagnosis and physiological changes in pregnancy. And number two is your normal and abnormal labor. Normal and abnormal labor. Abnormal labor. Number three, diseases in pregnancy. In pregnancy. And number three is diseases in pregnancy. And number four, abortion and ectopic pregnancy. Abortion and ectopic pregnancy. So these are the areas which are the high yield areas in terms of your obstetrics and gynae. Normal and abnormal menstruation. Normal and abnormal menstruation. Menstruation. Infections. Infections. CA gynae. Infections gynae and CA gynae. Apart from that, uterine fibroids. Uterine fibroids. So these are the high yield areas in obstetrics and gynecology. So this is kind of like a checklist, whether you know it or not. You have to tick this thing very fast away so that you can able to master and answer almost like a 60 to 70% of the question in the obstetrics and gynecology. Now, speaking about the obstetrics and gynecology, the very first area we are going to talk about is your basics of reproduction. Speaking of basics of reproduction, you have the primitive germ cells. Germ cells will form the ectoderm of yolk sac by 6th week. And then there you see the SRY gene. So SRY gene is your sexual determinated region. Okay, sexual determination region in your Y chromosome is so-called as your SRY gene. Sex determination region in Y chromosome is so-called as SRY gene. Okay, if the SRY gene is present, then your baby will be male and he may undergo spermatogenesis. If the SRY gene is not present, then the baby will be female. He's going to undergo oogenesis. Okay. If SRY gene is present, spermato. If SRY gene is absent, then it is a oogenesis. Okay. Speaking about that, there are certain basics you want to know. So size of the sperm, 55 microns. Duration, 72 to 74 days for the spermatogenesis. Both of them are single one-liners, which they may ask you as a straight FMG question. And begins at puberty in seminiferous tubules. Begins at puberty in seminiferous tubules. Apart from that, you have the spermatogonia. Spermatogonia on mitosis, it may convert into primary spermatocyte. Primary spermatocyte to secondary spermatocyte by the first meiosis. And secondary spermatocyte to spermatid. Okay, secondary spermatocyte to spermatid by second meiosis, or that is the meiosis 2. So spermatogonia to primary, primary to secondary, secondary to spermatid. Okay, and the spermatids attain maturity at the tail of epididymis, and there they form the sperm. and they form the sperm. And sperm will be moving into the female reproductive tract, and motility is the ions responsible for the sperm motility is calcium ions, and gene responsible for your motility is your Casper gene. Another important MCQ. Okay, and then spermatid to sperm conversion is mediated by spermiogenesis, where the duration is 14 days. So this is all about the spermatogenesis, people. What are the things you have to know in terms of your spermatogenesis is one, duration, 72 to 74 days. Second is size, 55 microns. And where spermatid attains the maturity at tail of your epididymis. Then what is the ion responsible for sperm motility? Calcium. Gene responsible, Casper gene. Apart from that, one spermatogonia gives rise to 16 primary spermatocytes. One spermatogonia gives rise to 16 primary spermatocytes, and one primary spermatocyte gives rise to 4 sperms. And one primary spermatocyte gives rise to 4 sperms. Then apart from that, oogenesis, speaking about the oogenesis, the size of the ovum is 120 to 130 micron, and size of the mature follicle is 18 to 20 nanometer. Fertilizable span of your ova is 12 to 24 hours. 12 to 24 hours. Apart from that, oogonium by 9th week. Oogonium will be converted into primary oocyte by 12th week. Primary oocyte will be arrested in diplotin stage. First meiosis will be arrested in diplotin stage or prophase of your meiosis 1. You may see the arrest, and then it resumes at the time of your puberty. Okay, it resumes at the time of your puberty, just prior to your ovulation, and then it can form a secondary oocyte by releasing a primary polar body or first polar body. First polar body is released at the time of puberty, just prior to the ovulation, where the resuming of your prophase of your meiosis 1 will be happening, and the secondary oocyte will be forming. Then the secondary oocyte will be arrested in metaphase. Okay, secondary oocyte will be arrested in metaphase and resumes at the time of your fertilization. Where they form the matured ovum and releases second polar body. So this is a oogenesis, people. So meiosis 1 arrested in prophase, while secondary oocyte meiosis 2 arrest is seen in the metaphase. Okay, first meiosis prophase and the second meiosis metaphase. Okay, apart from that, you have the size of the ovum, which is 120 to 130 micron. Number of mature follicle 18 to 20 nanometer. Fertilizable span of ova is 12 to 24 hours. Apart from that, hormonal regulation, GnRH releases FSH and LH, and both can act on Sertoli cells and Leydig cells. Sertoli cells secretes inhibin, where it inhibits your FSH, and Leydig cells will give us testosterone. It stimulates the spermatogenesis, and FSH and LH both can able to stimulate your spermatogenesis too. So this is the one of the important MCQ, which is a picture-based question. We already discussed that in the reproductive physiology. Yes or no? Not in the reproductive, endocrine physiology. We have discussed that. Next, spermatogenesis, oogenesis, we have talked about it. Now, speaking about the fertilization, what is the location of your fertilization? Ampulla of your fallopian tube. What is the location? Ampulla of your fallopian tube. And what is the gene responsible? Fertilin is the gene responsible for that. So for what is fertilization? Sperm plus ova will form a zygote. Zygote will form a morula. Morula moves from the fallopian tube to the uterine cavity, and there is a loss of zona pellucida by 5th day. Blastocyst formation will be there, and then there is a penetration of blastocyst into uterine mucosa. You have the sperm and ova which has been formed, that will combine to form a zygote, and then zygote will form a morula. Morula will leave the ampulla of your fallopian tube and attaches to your uterine cavity, where you see the loss of zona pellucida on the 5th day. Then you see the blastocyst formation, and then from the blastocyst formation, you may see the penetration of blastocyst into uterine mucosa. Okay, this penetration of blastocyst into the uterine mucosa is also known as implantation. And most common site of implantation was a typical question which was asked in the basics of your reproduction several times in the past paper, which is your posterior surface of your upper uterine segment. Very, 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 very important. Okay, what is the most common site of implantation? Posterior surface of upper uterine segment is so called as the most common site of implantation. Posterior surface of upper uterine segment is the most common site of implantation. And what are the phases of implantation? Apposition, adhesion, and invasion. While apposition is mediated by selectin and adhesion is mediated by integrin, invasion is mediated by enzyme matrix metalloproteinase. Okay, enzyme matrix metalloproteinase. Then you have a decidua. Endometrium after implantation is so called as decidua, where you see the decidua basalis, decidua parietalis, and decidua capsularis. Decidua basalis, parietalis, and capsularis. So whatever the endometrium after the implantation is so called as decidua, and decidua basalis is between your embryo and myometrium, while your parietalis is between your embryo and uterine cavity, while capsularis is the rest of the residual portion. Embryo to myometrium, that is your basalis, embryo to uterine cavity, which is your parietalis, rest of decidua, which is your capsularis. And parietalis and capsularis are combinedly called as decidua vera. Decidua vera, which is formed at 14 to 16 weeks of pregnancy. Another important MCQ. So in OBG, especially when it comes for the basics of reproduction, lot of straight question they may ask you. Okay. Apart from that blastocyst, you have a cytotrophoblast and syncytiotrophoblast, where all the hormone synthesis occurs in syncytiotrophoblast. Very, 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 very important MCQ. All the hormone synthesis occurs in syncytiotrophoblast, while cytotrophoblast is further divided into chorion fundosum and chorion lavi. Okay, chorion fundosum and chorion lavi. So fertilization, we have talked about the spermatogenesis and oogenesis. So size of the sperm is 55 microns, duration is 74 days, and maturity attains at the tail of your epididymis, and motility, sperm motility, ion responsible is calcium, while the gene responsible is your Caspar gene. One spermatogonia gives rise to 16 primary spermatocyte, and one primary spermatocyte gives rise to 4 sperms. One primary spermatocyte gives rise to 4 sperms. Apart from that, you have a oogenesis. Size of the ovum is 120 to 130 microns. Size of the mature follicle is 18 to 20 nm, while fertilizable span of ova is 12 to 24 hours. 12 to 24 hours. Then you have a oogonium, which is a 4th week, oogonium to primary oocyte, which is a 12th week, and primary oocyte to meiosis 1, arrested in a diploid stage or prophase of your meiosis 1, resumes at puberty just prior to ovulation, where you see the release of first polar body. Then it may goes to meiosis 2, which is arrested in metaphase, where you may see that it may resumes at the fertilization, where you may see the ovum and secondary polar body. Ovum and secondary polar body. Then you have a hormonal regulation, hypothalamus, where it gives rise to GnRH. GnRH will form a FSH and LH. FSH gives rise to Sertoli cells, and LH gives rise to Leydig. Sertoli cells synthesis inhibin, while the Leydig cell synthesis testosterone. Okay. Fertilization, location of fertilization, ampulla of fallopian tube. Gene responsible, fertilin. Zygote formation, morula. Morula leaves the uterine cavity. Loss of zona pellucida by the 5th day. Blastocyst formation, penetration of blastocyst into the uterine mucosa. That is so called as implantation. Implantation, most common site. Implantation, most common site, people. Posterior surface of your upper uterine segment. Posterior surface of your upper uterine segment is so called as fertilization. While phases of implantation, you have the apposition marked by selectin, adhesion marked by integrin, invasion is so called as enzyme matrix metalloproteinase. Enzyme matrix metalloproteinase. Then you have a decidua. Endometrium after implantation is so called as decidua, where we used to divide into basalis, parietalis, and capsularis. Basalis, decidualis, and parietalis and capsularis. Between your embryo and myometrium, basalis. Embryo and uterine cavity, parietalis. Rest of the decidua, capsularis. While parietalis and capsularis combine to form decidua vera, which is formed at 14 to 16 week of pregnancy. Which is formed at 14 to 16 week of pregnancy. And blastocyst, cytotrophoblast, chorion frondosum, and chorion laevi. While syncytial trophoblast, it's a hormone synthesis occurs in the syncytial trophoblast. Then you have a placenta, fetal membrane, and umbilical cord. While speaking about the placenta, the shape of the placenta is discoid and hemochorial. Okay, the shape of the placenta is discoid and hemochorial. Fetal surface, you see the chorionic frondosum. Chorionic frondosum will have a villi where the trophoblast grows here. Villi could be primary. Primary villi is at the 12th day of post-fertilization, 12 to 16 days secondary, while fetal circulation forms in tertiary by the day 17. By the day 17. Primary, 12 days of post-fertilization, secondary, 12 to 16 days, while tertiary, it forms here day 17 of post-fertilization. And maternal surface, decidua basalis, and at the term placenta, the term placenta are important high yield one where you have to know diameter is 15 to 20, thickness is 3, ratio of placenta to fetal weight is 1:2, while 1:1 by the 17th week of gestation. Another important MCQ, 1:1 placenta weight and fetal weight is 17th week of gestation, while the ratio of placenta weight and fetal weight at the term is 1:6, and thickness 3 centimeter, diameter 15 to 20 centimeter, and it has attachment upper part of uterine wall. Another very important MCQ. Upper part of uterine wall, especially posterior surface of the upper uterine segment or posterior surface of the upper part of uterine wall is very important. Okay, where you see the attachment. Okay, then apart from that, you have a maternal surface and a fetal surface in the placenta. Maternal surface and fetal surface. Maternal surface is rough, while the fetal surface is smooth, and the fetal surface is gray in color, and umbilical attaches at the center of your fetal surface. So placenta has maternal surface and the fetal surface. So the upper portion is your maternal surface, while lower portion is your fetal surface. Lower portion is your fetal surface, and lower portion is kind of like a smooth surface. Lower portion is kind of like a smooth surface where you see the attachment of your umbilical cord at the center. Umbilical cord at the center. Okay, and apart from that, here you may have a roughened surface. Apart from that, here you may have the roughened surface. Speaking about the roughened surface, the maternal surface contains the cotyledons or lobes. It contains the cotyledons or lobes which are separated by cotyledons or lobe which are separated by decidua spongiosum. Okay, which are separated by decidua spongiosum. Decidua spongiosum. Okay, apart from that, it contains a nitabush membrane, outer fibrinoid deposition in your syncytial trophoblast, and this nitabush membrane is absent in conditions such as placenta pravia, percreta, accreta, and increta. Okay, nitabush membrane is absent in placenta percreta, accreta, increta. So what is the placenta shape? Discoid, hemochorial. It contains two surfaces. What are they? Fetal surface, maternal surface. So fetal surface is so-called as chorionic frondosum, where the villi are found, while the maternal surface is decidua basalis. And maternal surface is roughened and red in color, and it is separated by lobes or cotyledon, and where you see the diagonal line of separation as decidua spongiosum. Decidua spongiosum, and it contains another thickened membrane over the syncytial trophoblast, which is your nitabush membrane. Nitabush membrane is absent in people. Where do you see the absence of nitabush membrane? Nitabush membrane is absent in placenta percreta, accreta, and increta. Placenta percreta, accreta, and increta. While the fetal surface is smooth and it contains gray in color, while it contains attachment of your umbilical cord at the center. And at the term placenta, thickness will be 3 centimeter, diameter will be 15 to 20, while the ratio of maternal and fetal weight is 1:6, and attachment is on the posterior surface of the upper part of your uterine wall. Okay, primary villi forms from day before 12 days, secondary villi 12 to 16, while tertiary villi over 17. And what are the hormones of placenta? One is your progesterone. Yes, hormones of placenta is very important, people. This hormones of placenta is very important. So first one, hormones of placenta, progesterone. 6 to 7 weeks, it's a corpus luteum. 6 to 7 weeks, it's a corpus luteum. 8 to 10 weeks, it's a placenta. Progesterone is synthesized in 6 to 7 weeks from the corpus luteum. By 8 to 10 weeks, it is synthesized from placenta. Estrogen, most common during the pregnancy is estrogen 2, type 2. Most specific one is E3. Okay, estriol. Apart from that, human placental lactogen, which is your HPL, syncytial trophoblast, and peaks at 34 to 36 weeks. Peaks at 34 to 36 weeks. And apart from that, the T half of the HPL is 10 to 30 minutes, which was asked one time in FMGE. What is the T half of HPL? What is the T half of HPL, which is 10 to 30 minutes. Apart from that, HCG, speaking about the HCG, the beta one is secreted in the during the pregnancy, and the T half is 24 to 36 hours, and doubling time is 2 days. Doubling time in every 48 hours, you may see beta HCG doubling time. Missing period, 100 international unit per liter. Okay, if whenever the patient is having a missed period, that's the time they have a 100 international unit per liter. And apart from that, the beta HCG will be peaked in 70 days, and it started growing down and goes to minimum in 16 weeks. Okay, maximum in 70 days, minimum in 16 weeks, and disappears 48 hours after delivery in urine. 48 hours after delivery in urine. So what are the 4 hormones? Progesterone, estrogen, HPL, HCG. Progesterone 6 to 7 weeks secreted by corpus luteum, 8 to 10 weeks by placenta. Estrogen, most common during the pregnancy is E2, most specific one is E3. HPL, syncytial trophoblast, peaks at 34 to 36 weeks, and HCG, T half is 24 to 36 hours, doubling time is 48 hours, missed period is 100 international unit per liter, maximum concentration is seen at the 70 days, while the minimum concentration is seen at the 16 week, and disappears 48 hours during after delivery in the urine. 48 hours after delivery in urine. So these are the hormones of placenta, people. So we have done with the placenta completely. So how many surface? 2 surface, maternal and fetal surface. Which one is a roughened surface? Which one is a roughened surface? Which is a maternal one. Which one is the smoothened surface? Which one is the smoothened surface? Which is the fetal one. Okay, Nitabush membrane is absent in people. Nitabush membrane is absent in placenta percreta, accreta, and increta. Apart from that, anomalies of your umbilical cord incision. So we are having a normal umbilicus which is attaches near the center. Normal umbilicus which is attaches near the center, while the marginal one which is attaches near the margin of placenta, which is also called as Bartell-Door placenta. Okay, which is also called as Bartell-Door placenta. And then furcate placenta, which is attached to the center, but it does not contain the Wharton jelly. Very important MCQ. Furcate placenta is the placenta where you see the umbilical cord which is attaches to the center, but it do not contain a Wharton's jelly. Okay, then velamentous, splitting of the vessels prior to the insertion is velamentous, which can increases the risk of vasa previa. Okay, splitting of vessels prior to insertion, which can increases the risk of vasa previa. Then you have amniotic fluid. Contributor of your amniotic fluid early pregnancy is maternal plasma, second trimester ECF, and more than 20 weeks fetal urine and lungs. Very important MCQ. Who is the major contributor of your amniotic fluid in the third trimester or over the 20 weeks? The over the 20 weeks, the major contributor is fetal urine and lungs. Very important, people. Okay, you should not miss. Who is the major contributor of your amniotic fluid on the 22nd week of pregnant women? Fetal urine. Fetal urine. And the colors of your amniotic fluid are very, very important. Colorless is preterm, straw colored is term, and green color is fetal distress or breach, and golden yellow, RH incompatibility, saffron colored, post-dated pregnancy, tobacco juice, IUFD, intrauterine fetal death. So IUFD, tobacco juice, and post-dated pregnancy, saffron, RH incompatibility, golden yellow, listeria or fetal distress or breach, it is a green in color. And apart from that, straw colored is term. So contributor, early pregnancy is maternal plasma, second trimester it is ECF, third trimester it is fetal urine, or over 20 weeks it is fetal urine. Colorless, preterm, straw colored, term, green colored amniotic fluid is seen in fetal distress or breech presentation or listeria infection. Golden yellow, RH incompatibility, saffron, post-dated pregnancy, tobacco juice, intrauterine fetal death. Apart from that, we are having an oligohydramnios and polyhydramnios. Oligohydramnios is less than 200 ml at term, AFI of less than 5 centimeter, and polyhydramnios is more than 2 liter at term, or AFI of more than 25 centimeter, or AFI of more than 25 centimeter. So oligohydramnios, most common complication is pulmonary hypoplasia, while most common cause is idiopathic. Most common cause of oligohydramnios is idiopathic, or maybe it is due to any conditions that can able to result in oligohydramnios, that is your drugs, or maybe IUGR, or maybe leaking, or maybe any maternal conditions, or maybe post-term, or maybe premature rupture of membrane, amnion nodosum, or renal anomalies are the one which they used to call it. Okay, or they which they used to call it. But most of the things, most common cause of your oligohydramnios is your idiopathic. So the measurement, oligohydramnios is less than 200 ml at term, or the AFI of less than 5 centimeter. Poly, more than 2 liter per term, or the AFI of more than 25 centimeter. Very, 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 very important MCQ this is. Okay. Apart from that, physiological changes in pregnancy. So what is a pregnancy? State of having a concept as normally or abnormally in the uterus or occasionally elsewhere is so called as a pregnancy. And what is the duration of your pregnancy, people? What is the duration of your pregnancy? Either 10 lunar month or 9 calendar month plus 7 days, or 40 weeks or 280 days. Okay. What is the normal duration of your pregnancy? Either a 10 lunar month or 9 calendar month plus 7 days, or 280 days, or 40 weeks. Any of those things you can able to call. And the first trimester is 1 to 12 weeks. Second is 13 to 28, while third trimester is 29 to 40. Okay, first is 1 to 12, second is 13 to 28, while the third is 29 to 40. Apart from that, Naegele's formula, you know the Naegele's formula, right? Yes or no? They may ask you like the period of LMP they may give you, and they may ask you what is the EDD. They may ask you what is the EDD. Remember, if they are given you the LMP as this particular date, you have to calculate the EDD. So how do you calculate the EDD? Consider like a 1 for 2022 as the LMP. 1 for 2022 as the LMP. So if 1 for 2022 was the LMP, then you can able to count. So DD plus 7, which is your, which is 8, and MM minus 3, which is your 1, and a triple Y plus 1, which is your 2023, which is your 2023. So if LMP is 1st of April, then EDD is 8th of Jan. EDD is 8th of Jan. Okay, you understood that, people? Or if you have to count it back. For example, your LMP is, if your LMP is 15th of January 2022, then what is the EDD? If you are counting it on the forwards, DD plus 7, which is equal to 22, and MM plus 9, which is equal to 1 plus 9, 10, 22, October 2022 is the EDD. If you count it forward, you have to do this. If you count it backward, you will get this type of answers. You will get this type of answers. So these are the possible causes. These are the things where you have, this is how you have to calculate the EDD, which was asked several times in FMGE as well as in NEET PG. Okay, FMGE and NEET PG. They're going to give you the LMP and they're going to ask you the EDD. They're going to give you the LMP and they're going to ask you the EDD, so that you have to remember that. Then signs of pregnancy. Presumptive signs of pregnancy are amenorrhea, nausea, and the frequency of micturition. While you have the positive signs, fetal parts will be palpated, fetal sounds will be heard on auscultation, evidence of embryo at the 6th week, and X-ray shows fetal skeletal shadow by 16th week. A skeleton shows a fetal skeletal, X-ray shows a fetal skeleton shadow by 16th week, and evidence of embryo at 6th week, fetal heart sounds on auscultation, and fetal parts on palpation. Okay, what are the probable signs of pregnancy? You have this abdominal enlargement, Braxton Hicks contraction, Goodell sign, Hagar sign, Palmer sign, Orlander sign, and Ballotment, and Ladden sign, and Pishkasek sign. All of these are the possible probable signs of pregnancy, where you may see the what are these signs. So Goodell, it is softening of cervix, people. Softening of cervix is Goodell, and softening of lower portion of uterus is Hagar, and bluish purple discoloration of vaginal mucous membrane, it is due to Chadwick. Softening of uterus after 6 weeks, it is Ladden. Increased pulse at the lateral fornices, it is Oslander. Rhythmic contraction of uterus on bimanual is Palmer. Okay, rhythmic contraction of uterus on bimanual is Palmer. So I used to remember it with the with this like the image. Okay, if it is in the cervix, softening. If the cervix is softening, then you may see the Goodell. Then you may see the Goodell. Then the uterus is softening, then you may see the Hagar. Then you may see the Hagar. Softening is Hagar. I rather say softening is Hagar. Where is it? Softening, it is Hagar. Hagar on the lower portion. If it is a time one, if it is softening after 6 weeks, then it is a Ladden sign. It is a Ladden sign. Okay, then you may see the bluish purple discoloration. Then you may see the bluish purple discoloration. Then you may see the bluish purple discoloration, which is your Chadwick sign. Chadwick sign, and increase the pulse. Increased pulse with the contraction. Contraction is Palmer. Increased pulse is Oslander. Oslander sign and Palmer sign. And Palmer sign. Palmer sign indicates there is a rhythmic contraction on bimanual. So you have to remember, softening of cervix is Goodell. Softening of lower portion of uterus is your Hagar, while softening of uterus after 6 weeks is your Ladden. And you have this bluish purple discoloration is of vaginal mucus is Chadwick, and you have the rhythmic contraction or increased pulse in the lateral fornix is your Oslander. Rhythmic contraction of uterus on the bimanual is your Palmer sign. On the bimanual is your Palmer sign. So this is all about the important signs in pregnancy, people. So what is a Palmer sign? What is a Palmer sign? Regular rhythmic contractions of the uterus on bimanual is a Palmer sign. What sign is a softening of uterus after 6 weeks? What sign is the softening of uterus after 6 weeks? Ladden sign. And what sign is the softening of cervix? Which is your Goodell. And what sign is the softening of uterus on the lower portion? Hagar sign. What sign gives a bluish purple discoloration of your vaginal mucosa? Bluish purple discoloration of your vaginal mucosa, which is your Chadwick sign. Which is your Chadwick sign. Okay, clear about that? Okay, very good. Now speaking about the next portion, speaking about the next portion is the systemic changes. Okay, systemic changes. So what changes you may see it in the CNS? The first change you may see it in the CNS is enlargement of your pituitary gland, people. Enlargement of your pituitary gland. Apart from that, you may see there is a cardiovascular system. I used to remember it with this sequence. What is the sequence? I used to remember it like whenever there is a more progesterone, there is a more smooth muscle contraction, people. Sorry, it's more smooth muscle relaxation. More progesterone, more smooth muscle relaxation. Whenever more smooth muscle relaxation, there is a decrease in the vascular resistance, and a decrease in the vascular resistance, then there is a decrease in the systolic BP and the decrease in the diastolic BP of about 10 to 15%. Okay, so BP, speaking about the BP, because of the decrease in the SPR, you may see there is a decrease in systolic and diastolic BP. Okay, clear about that? So pregnancy is a state of hypercoagulability, and pregnancy is the state of hypervolemic state. So whenever the blood volume is increasing, so blood volume increases by 40% in your pregnancy, as we studied. Yes or no? Whenever the blood volume increases by 40%, then what happened to the plasma volume? Plasma volume also increases. When plasma volume increases, then what about the blood count? Blood count are the cells. The cells will also increase. But what happens here is, because of the blood volume increases, you have your cardiac output increases. So speaking about that, as I said, pregnancy is a hypervolemic state where your blood volume increases by 40% and your plasma volume increases by 50%. Since your plasma volume increases by 50%, the cells tries to compensate. So your RBC volume increases by 30% and your WBC volume will also increases, and you may see there is a plasma volume increase by 50% and RBC volume increases by 30%. So dilutional anemia you may see. Okay, dilutional anemia you may see, where you may see there is a decrease in the hemoglobin concentration, HCT, and viscosity of the blood. You may see it in this patient. So hypercoagulability, dilutional anemia with the plasma volume and blood volume and cardiac output rise, you may see it in the cardiovascular effect in the pregnancy. And BP, decrease in BP. Why? Due to the smooth systemic vascular resistance decrease. Why there is a systemic vascular resistance decrease? Because of the smooth muscle relaxation. Why there is a smooth muscle relaxation? Because of the lack of progesterone. And it's important, another important thing is clotting factor 11 and 13 decreases, people. Clotting factor 11 and 13 decreases in pregnancy. Very, 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 very classical MCQ in terms of your physiological changes in pregnancy. Okay, clotting factor 11 and 3 decreases. Cardiac output increases or decreases? Cardiac output increases or decreases? Increases. Systolic BP increases or decreases? Decreases. Diastolic BP increases or decreases? Decreases. And pregnancy is a hypercoagulable state. RBC volume increases. WBC count increases. Factor 11 and 3 decreases. Okay, and dilutional anemia. Yes, you may see the dilutional anemia. Then you have a gastrointestinal system. Speaking about the gastrointestinal system, you have the morning sickness, and hyperemesis gravidarium is associated with the gastrointestinal system, where you may see the elevated alkaline phosphatase level. And you may also see the atonicity of your gallbladder. So more contractions, and you may see the atonicity. Then you have a renal system. Kidney size increases by 1 to 1.5 mm. So you may see the risk of pyelonephritis. GFR rises, very, very important. GFR rises by 50%. The BUN and the creatinine decreases by 25%. Okay. Cardiac output increases. Plasma volume increases. Hypercoagulable state. Pituitary size increases. Kidney size increases. Gastric emptying time, increase in the vomiting, gastric motility. Yes, increase in the gastric motility. increased gastric emptying time, elevated alkaline phosphatase level, and there will be a GFR increase by 50%. Creatinine and BUN decreases by 25%. 25%. Very, 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 very classical MCQ. And apart from that, musculoskeletal system changes. You may see the spider angiomata, hyperpigmentation of nipples. You may see there is a line which is coming on to the over the belly, which is a linea nigra, and melasma or colasma will be there. Increased risk of carpal tunnel syndrome in the pregnant women will be there. Okay, increased risk of carpal tunnel syndrome in the pregnant women will be there, and compression of lateral cutaneous nerve of thigh will be there. And apart from that, you may see the heavy lower back pain. So musculoskeletal and dermatological, melasma and colasma, linea nigra, hyperpigmentation of nipples, spider angiomata, compression of lateral cutaneous nerve of thigh, carpal tunnel syndrome risk rises, and apart from that, lower back pain will be there due to the gravity. Apart from that, endocrine is a hyperestrogenic state. So marked increase in the estrogen and the progesterone, HCG, HPL, everything will be there. And apart from that, because of the elevated estrogen, elevated TBG, thyroglobulin binding, thyroglobulin, and elevated thyroglobulin, you may have the elevated total T3 and T4, but free T3 and T4 remains constant. Elevated total T3 and T4 will be there, but there will be a constant free T3 and T4. Okay, total T3, T4 elevated, free T3, T4 remains constant. Very, 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 very classical MCQ. And apart from the respiratory system, pregnancy is a state of respiratory alkalosis with compensated metabolic acidosis. Respiratory alkalosis with compensated metabolic acidosis, where you see the increase in tidal volume, minute ventilation, inspiratory capacity, minute O2 capacity, O2 demand, and decrease in FRC, ERB, RB, TLC, and PCO2. Okay, decrease in FRC, ERB, RB, TLC, and PCO2. So remember one thing, pregnancy is a hypercoagulable, hyperestrogenic state where you see the respiratory alkalosis with the compensated metabolic acidosis. Okay, where you see the respiratory alkalosis with compensated metabolic acidosis. Then there is an interesting syndrome called as Meingert syndrome, where you see the compression of IVC by the gravid uterus. So normally, whenever the patient is lying down straight, the patient IVC has been compressed by your gravid uterus. So the patient may experiences a hypotension and dizziness. So managing the patient to the management of this condition will lies on placing a patient on a lateral side and asking the women to lie on a side position, not on the supine position, So that's why it is so called as Meingert syndrome or supine hypotension syndrome. Okay, this is all about the physiological changes in pregnancy, people. Apart from that, remember one of the classical important MCQ, smoking causes IUGR. One of the very key MCQ, one-liner MCQ, they asked several times in the past. Remember, smoking can never be a part of a maternal weight gain. Smoking can never be a part of the maternal weight gain. Okay. Apart from that, in pregnancy, there is a decreased albumin globulin ratio. And pregnant uterus, weight will be 1 kg, length will be 35 centimeter, capacity will be 5 liters. Okay, capacity will be 5 liters. And whenever a pressure is put on a cervix, the nerve supply in the cervix causes uterine contraction and labor. When you put a pressure on the cervix, uterine contraction will be there. That is so called as Ferguson reflex. Okay, that is so called as Ferguson reflex. Apart from that, you may see the isthmus of uterus forms the LUS, lower uterine segment, during a pregnancy, one of the classical MCQ. And a colostrum, which is the first one, first milk, where it is rich in a potassium, fat, and casein, which we studied that in the PSM. Apart from that, you may see that there is a pseudocyesis, psychological disorder, that the women have a strong belief that she is a pregnant, although she is not pregnant. That condition is so called as pseudocyesis. Okay, women have a strong belief that she is pregnant, but she is not pregnant actually. There is a pseudocyesis. and lower uterine segment during the pregnancy is formed by isthmus of uterus. And what is a Ferguson reflex? When you put the pressure on the cervix, the uterine muscle will contract. Okay, uterine contraction will be there. In pregnancy, you may see the decreased albumin globulin ratio. Smoking causes IUGR, not the weight gain. IUGR, not the weight gain. One of the classical MCQ which I wanted to mention over here, people. Clear about that? Physiological changes in pregnancy? Clear about the physiological changes in pregnancy? Shall I move on to the next topic? So we have done the basics of reproduction and we have done the physiological changes in pregnancy. One of the classical thing you have to remember, people. Okay, shall we move on to the next area of interest? Shall we move on to the next area of interest? Okay, next area of interest is another 7-star rated topic where you may at least expect one question in this area. One is your maternal pelvis and fetal skull, people. Maternal pelvis and fetal skull. So speaking about the maternal pelvis and fetal skull, gynecoid pelvis, which is a female type and most common type where the subpubic angle is 90 degree, and you may see the periauricular sulcus, and you may see the periauricular sulcus, and most common position of head in gynecoid is left occipitotemporal or LOA. Okay, LOT or LOA you may see in this patient. And apart from that, you may see the broad greater sciatic notch. So gynecoid pelvis, female type, most common position is LOT or LOA. Subpubic angle is 90 degree. Periauricular sulcus positive. Broad greater sciatic notch. While android pelvis, male type, heart-shaped pelvic inlet. Subpubic angle is less than 90. Prominent ischial spine. Engagement is delayed. Deep transverse arrest or persistent occipito-posterior position where only instrument delivery is possible. Deep transverse arrest or persistent occipito-posterior position where the instrument delivery is possible. Anthropoid pelvis, only pelvis with the APD over the transverse diameter. APD is greater than the transverse diameter. Most common position is direct occipito-posterior position where you may see the phase 2 pubes delivery. Where you may see the phase 2 pubes delivery. And the platyploid pelvis is the least common type. Pelvis, the only pelvis with the transverse diameter is more than the APD. Asynctalism positive, and you can do only C-section. And only you can do the C-section. So 4 types of pelvis. What are the things you have to remember in this 4 type? Gynecoid, female type, most common position, LOT or LOA, where you may see there is a periauricular sulcus and broad greater sciatic notch. At least remember, gynecoid, female type, most common type, and most common position of head is LOT or LOA. Android, male type, heart-shaped pelvic inlet, and apart from that, you may see there is a deep transverse arrest or persistent OPP. DTA or persistent OPP, instrumental delivery. Instrumental delivery. Anthropoid pelvis, only pelvis, anteroposterior diameter is over the transverse diameter. Most common position is direct OPP, phase 2 pubes delivery. Platyploid pelvis, pelvis with the transverse diameter is far more than the anterior-posterior diameter. Asynctalism, C-section. Asynctalism and C-section. So the important questions I'm gonna ask you here is, deep transverse arrest is seen in which of the following pelvis? Android. Which one is a female type? Gynecoid. Which one is showing a phase 2 pubes delivery? Anthropoid. Which one is showing a asynctalism? Platyploid. Which one is the most common type? Gynecoid. Which one is the least common type? Platyploid. Which one is the one where you may see the instrumental delivery is possible? Android. Direct occipito-posterior position is seen in Anthropoid. Persistent OPP is seen in Android. And what type of position is seen in gynecoid? LOT or LOA. LOT or LOA. Okay, these are the important types of pelvis. And apart from that, you may have the contracted pelvis. So speaking about the contracted pelvis, we have the types of contracted pelvis. So vitamin D deficiency, rachitic or osteomalacic pelvis, you may see, are the absence of ala of sacrum. If one ala is absent, then you may call it as a Naegele's pelvis. And if two ala is absent, then you may call it as a Robert's pelvis. Then you may call it as a Robert pelvis. So ala of sacrum, if one ala of sacrum is absent, it is a Naegele's pelvis. If two ala of sacrum is absent, then it is a Robert's pelvis. Then it is a Robert's pelvis. Then which one is the smallest diameter? Small pelvic diameter is your interspinous diameter, which is 10.5 centimeter between your two ischial spine. And apart from that, the only conjugate which can be assessed clinically is your diagonal conjugate, which is your diagonal conjugate between the lower part of your, between your lower part of your pubic symphysis to the top of your sacrum, and narrowest diameter of your pelvic inlet is your obstetrical conjugate. Okay, narrowest part of your pelvic inlet is your obstetrical conjugate. Only conjugate assessed clinically is your diagonal. Smallest pelvic diameter is your interspinous diameter, which is 10.5 centimeter. Then fetal skull, from the diameters, the positions, and the baby's presentation. Suboccipitobregmatic, vertex position, where you see the nape of the neck to the center of bregma, and suboccipitofrontal, nape of neck to anterior end of anterior fontanelle, where you see the vertex position. Occipitofrontal, occipital eminence to root of nose, vertex position. Mentovertical, which is the largest one, from the midpoint of chin to the highest point of sagittal suture. From the midpoint of chin to the highest point on sagittal suture, where you see the brow presentation here. And submentovertical, junction of floor of mouth and neck to the highest point on sagittal suture, where you see the brow presentation. And submentobregmatic, junction of floor of mouth and neck to center of bregma, where you see the face presentation. Where you see the face presentation. So suboccipitobregmatic, nape of neck to center of bregma, where you see the vertex. Suboccipitofrontal, nape of neck to anterior end of anterior fontanelle, vertex. Occipitofrontal, occipital eminence, root of nose, vertex. Mentovertical, midpoint of chin to highest point of sagittal suture, where you see the brow presentation. And submentovertical, junction of floor of mouth and neck to highest point on sagittal suture, where you see the brow presentation. Submentobregmatic, junction of floor of mouth and neck to center of bregma, where you see the face presentation. Where you see the face presentation. So these are the fetal skull measurements, people. These are the fetal skull measurements. These are the maternal pelvis and the fetal skull, which you have to know. This page is also one of the page where you sit in the lunch time and you read this. Okay, you sit in the lunch time, you got to get a read of one page, and this page is one among that page, and this page is one among that page. Mark it and save it. Okay, so apart from that, you may have a normal and abnormal labor. Speaking about the normal and abnormal labor, so what is the criteria for your eutosia, that is your normal labor? One is it should be a spontaneous in onset. It should be spontaneous in onset, vertex presentation, no undue prolongation or without undue prolongation, and without complication. Okay, without complication, that is so called as eutosia. That is a normal labor. What are the criteria of your eutosia? Spontaneous onset, vertex presentation, without undue prolongation, and without complication. If any of this deviation is there, then it is so called as dystocia. Then it is so called as dystocia. So what are the characteristics of the true labor pain? You are having a true labor and a false labor. One of the characteristic feature of your true labor pain is your show. Show will be there. Apart from that, you may see in the true labor pain, you may see there is a bag of water, and you may see there is a pain at the lower abdomen, which is radiating to back, and you may see cervix will start dilating, and you may see that there is a cervical dilatation, pain at the lower lower abdomen radiating to back. You see there is a bag of water formation, and you see there is a show cervical dilatation, or the classical sign of true labor pain, people. Okay, then uterine contraction. From the uterine pacemaker to uterus, the contraction rate is 2 centimeter per second, and uterine pacemaker is located at carno of your uterus. Okay, two uterine pacemaker is located at the carno of your uterus. And what is the typical contraction? 3 contractions in 10 minutes, each last for 45 seconds at 220 Montevideo unit power. 3 contractions in 10 minutes of each being last for 45 seconds at 220 Montevideo unit of power is so called as typical uterine contraction. Okay, uterine contraction will last from 2 centimeter per 2 centimeter per second, which is going from uterine pacemaker to the uterus, where the uterine pacemaker is located at the carno. And what is a typical uterine contraction? 3 contractions in 10 minutes, each lasting for 45 seconds at 220 Montevideo unit. At 220 Montevideo unit. And stages of labor, we are having 4 stages of labor. What is the first stage? Onset of true labor to cervical dilatation is first stage. Cervical dilatation to expulsion of fetus is second stage. So expulsion of fetus to expulsion of placenta is third stage. And fourth stage is post-placental 1 hour observation period is your fourth stage. So onset of labor pain to cervical dilatation, first stage. Cervical dilatation to expulsion of fetus, second. Expulsion of fetus to expulsion of placenta, third. Post-placental 1 hour observatory period, that is your fourth. That is your fourth. Next is your latent phase. The first stage is divided into latent and active phase. Pain to 5 centimeter cervical dilatation is latent. 6 to 10 centimeter cervical dilatation is active phase. So what is a latent? What is a latent? Pain to 5 centimeter dilatation. What is a active phase? 6 centimeter to 10 centimeter of cervical dilatation. Okay, pain to 5 centimeters is latent, 6 to 10 centimeters active. Duration, nulliparous it is 12 hours, multiparous it is 8 hours. Nulliparous it is 12 hours, multiparous it is 8 hours. For the latent, cervical dilatation, nulliparous in the active is 1.2 centimeter per hour, while multiparous is 1.5 centimeter per hour. Okay, while the multiparous is 1.5 centimeter per hour. Apart from that, how do you call that is a prolonged latent phase? If the nulliparous exceed more than 20 hours, it is a prolonged latent phase. Multiparous of more than 14 hours, it is a prolonged latent phase. Normal duration of latent is 12 to 8. More prolonged if the nulliparous is more than 20, multiparous is more than 14. So what are the causes? One is your excessive sedation, poor cervical condition, or it may be the false labor. Or it may be the false labor. And active phase, okay, active phase arrest, contraction positive, but there is no cervical dilatation. And there may be lack of contraction and dilatation. Treatment is C-section. So first stage of labor, how many phases, people? 2 phases. What are they? Latent phase, active phase. What is a latent phase? What is latent phase? What is latent phase, people? Faster. Onset of pain to 5 centimeter dilatation is your latent phase. Duration, nulliparous 12 hours, multiparous 8 hours. Prolonged if nulliparous more than 20, multiparous more than 14. And causes excessive sedation, poor cervical dilatation, false labor. Poor cervical dilatation and false labor. Okay, then speaking about the active phase, 6 centimeter to complete dilatation of your cervix, which is your 10 centimeter. Cervical dilatation rate, nulliparous 1.2, multiparous 1.5. And descendant of head, nulliparous 1 centimeter, multiparous 2 centimeter. Active phase arrest, when do you call that there is an active phase arrest? Either there is a dilation, there is no dilation and only contraction, or both dilation and contraction is absent. Treatment of choices, C-section. Okay, in terms of your active phase arrest. Okay, in terms of your active phase arrest. Next is a second stage, cervical dilatation to expulsion of fetus. Duration is 1 hour in nulliparous and 30 minutes in multiparous. And prolonged if nulliparous is 2 hours and multiparous is 1 hour. And depending upon the head station, if it is below +2 head station, forceps or vacuum delivery. If it is above +2 station, delivery by C-section. Delivery by C-section. That's the typical algorithm, people. Okay. Expulsion of fetus, duration of your second stage of labor, nulliparous 1 hour, multiparous 30 minutes. Prolonged if nulliparous more than 2 hours, multiparous more than 1 hour. Depends on the head station. Below +2, forceps or vacuum. Above +2, delivery by C-section. Delivery by C-section. Then you have a third stage, expulsion of fetus to placenta. Duration with AMTSL 5 minutes. Without AMTSL, it is 15 to 20 minutes. What is the AMTSL? That is active management of third stage of labor, is so called as AMTSL. Okay, what are the components of AMTSL? One is your use of oxytocin. You have to give a tocolytics first. Oxytocin, T-half is 3 to 5 minutes. Don't give it as a IV bolus. Remember, don't give oxytocin as a IV bolus. One of the very, very important MCQ they may ask you in terms of your negation, and you should also note in order to know for the clinical setup. Never ever give the oxytocin IV bolus in terms of third stage of labor. Delayed cord clamping, contraindicated in fetal hypoxia, known case of heart disease, IUGR and RH negative female. Okay, apart from that, controlled cord traction, you may see the modified branded Andrews technique. Okay, modified branded Andrews technique, you can use it for the controlled cord traction. Apart from that, intermittent uterine tone assessment. Intermittent uterine tone assessment you can able to do. These are the 4 components. Use of oxytocin, delayed cord clamping, controlled cord traction, intermittent uterine tone assessment. Controlled cord traction is by using a modified branded Andrews technique. And apart from that, prolonged cord clamping is contraindicated in fetal hypoxia, known case of heart disease, IUGR and RH negative fetus. RH negative fetus. Apart from that 4th stage, which is a observatory period, and cardinal movements, you already know: engagement, descent, flexion, internal rotation, crowning, extension, restitution, and external rotation. So there is a mnemonic which you can able to follow. Every decent female I choose to employ rises exponentially was the mnemonic. Every decent female I choose to employ rises exponentially is the mnemonic. Rises exponentially is the mnemonic, where you can able to see the cardinal movements of labor. Among that, engagement is very, very important, where what is meant by engagement? Greater transverse diameter of your presenting part will be passed through the pelvic inlet, is so called as engagement. So engagement could be of asynctalism and synctalism. So synctalism, fetal head, where the sagittal suture lies in the transverse diameter. Sagittal suture lies in the transverse diameter, that is synctalism. Asynctalism, anterior and posterior. Anterior is negalis obliquity, where the fetal head or sagittal suture of the fetal head lies on the sacral promontory. Okay, sacral promontory. While Litzman obliquity, sagittal suture lies on the pubic symphysis. Sagittal suture lies on the pubic symphysis, and delivery of fetal head is used with the modified Ridgen maneuver. Delivery of fetal head is by the modified Ridgen maneuver. Okay, apart from that, you have an abnormal third stage of labor, where the first part is your PPH, and the second is your uterine inversion, and third is your placenta accreta, and fourth is your amniotic fluid embolism. So before we move on to the abnormal third stage of labor, so take a 10 minutes of break and come back exactly by 21:10. So we can proceed with the abnormal third stage of labor. Today, the session lasts for 2.5 hours to 3 hours, where we finish the OBG completely. Okay, take a good time and just take a 10 minutes of break and come back by 21:11 so that you can able to proceed now. Okay, take a break, people. Okay, people, shall we resume? Shall we resume for today? The next session of obstetrics and gynecology. We are resuming the next session of obstetrics and gynecology, people. Speaking about the next session of your obstetrics, which is your the abnormal third stage of your labor. So PPH, the first one is your PPH. So postpartum hemorrhage, where the primary is less than 24 hours and secondary is more than 24 hours. Most common cause of primary is atonic, while most common cause of secondary is retained placenta. Most common cause of secondary is retained placenta. And how do you calculate the obstetrical shock index? Well, the normal obstetrical shock index is 0.7 to 0.8, where you can able to divide the heart rate by your systolic blood pressure. Okay, obstetrical shock index greater than 1 indicates there is a massive hemorrhage. There is a massive hemorrhage. Okay, fine. There is a PPH is more common in placenta bilobeta and or suction curated placenta. Okay, fine. So PPH primary is less than 24, secondary is more than 24 hours. Most common cause of primary is atonic, while the secondary is a retained placenta. We already knew. So how do you manage the PPH, people? So management, resuscitation first. First, resuscitate the patient. Don't let the patient to go in the hypovolemic shock, and resuscitate first, and then assess the uterine tone. And then assess the uterine tone. If it is a normal uterine tone, then the PPH is more or less likely to be the traumatic. Then the uterine tone is normal, then the PPH is more or less likely to be the traumatic, where you can do the laceration or hematoma will be there, and you can able to manage it accordingly. So if it is the large hematoma, then you have to, for a vulva, you have to do the pudendal artery will be the most common artery you have to ligate it, and for a vagina, it should be the uterine artery. Okay, for vagina, it should be the uterine artery is the size of the site of the bleeding. If it is a pelvic hematoma, then vulva is the most common site of bleeding. And for a small hematoma, you can do the conservative management. And if there is a perineal tear, okay, the traumatic, we have talked about the hematoma small conservative, then you have to, if it is a larger hematoma, you have to ligate the respective artery. Most common artery for the vaginal one is your uterine artery, vulva one is your pudendal artery. And apart from that, if you see the perineal tear, you have to grade it primary, secondary, tertiary, or quaternary. If it is a primary, then vagina only. If it is a secondary, vagina along with the muscles. If it is a tertiary, then there will be an anal sphincter involvement. Okay, the 3A less than 50% of external, B is more than 50% of external, while C is both internal and external, all the things you know. And 4 is anal epithelium. So primary, tear involving vagina, secondary, vagina plus muscle, third is anal sphincter, fourth is anal epithelium. Okay, so perineal tear is there. How do you prevent it? Either by doing a Ridgen maneuver. If the perineal tear is primary to secondary, then you can able to repair the vaginal mucosa, their respective skin and the muscle. Vaginal skin, mucosa, and the muscle repair will be a treatment of choice for primary and secondary vaginal tear. If it is a tertiary or quaternary, then you have to do the repair of your anal epithelium. Apart from that, internal and external anal sphincter, vaginal mucosa, muscle, and skin. Along with the vaginal mucosa, muscle, and skin, you have to do the anal epithelium, internal and external anal sphincters repair also you have to do. Okay, clear about the traumatic one. So we resuscitated, we assessed the uterine tone. Uterine tone was normal. So we found that it is due to the traumatic one. Traumatic one, you may see there is a laceration or there is a hematoma. Based upon the hematoma, we can able to do the, if it is small, conservative, large, you have to ligate the respective artery of bleeding. Most common vaginal is uterine artery, vulva is your pudendal artery. You already knew it. Okay, fine. Apart from that, if there is a perineal tear, we grade it first. Primary is involving vagina, secondary is vagina plus muscle, tertiary is vagina plus muscle plus anal sphincter, ABC. Less than 50 external is A, more than 50 external is B, external and internal is C. And for quaternary is anal epithelium. Primary and secondary repair, and tertiary and quaternary is also repair. But the primary and secondary, you repair the vaginal area, while tertiary or quaternary, you repair the anal area along with the vaginal area. And prevention of perineal tear by doing the Ridgen maneuver. Okay, This is a normal tone PPH. If the tone is less than atonic PPH, then you have to give a utrotonics first. Utrotonic or tranexamic acid along with the massage. Tranexamic acid, massage followed by the utrotonic. Then you have to, for a mechanical, you can do the bimanual compression, or you can do the uterine massage, or you can do the mask technique. And for surgical, B-Lynch sutures you can do, or radiographic embolization you can do, uterine artery ligation you can do, internal iliac artery ligation we can do, or followed by the hysterectomy. If the bleeding is totally not controlled, then you can do the hysterectomy. These are the management protocol of your PPH. Okay, this is the management protocol of your PPH. Cervical tear, most common location is 3 o'clock position. Another important MCQ. So PPH, primary or secondary. Primary is less than 24 hours. Most common causes. Atonic PPH. Secondary, more than 24 hours. Most common causes. Faster people, most common causes. Retained placenta. Okay, normal obstetrical shock indexes 0.7 to 0.8. Greater than 0.1, greater than 1 indicates massive hemorrhage. So management of choices: resuscitate, assess the uterine tone. Normal uterine tone, then the then the cause of the problem is, for a normal uterine tone, then the cause of the problem is traumatic. If it is the decrease in uterine tone, then the cause of the problem is atonic. Atonic, how do you manage? Give him a utrotonics first, contract the uterus, then you can give a tranexamic acid, and then massage you can do it, and then you can able to solve it. If it is not getting involved, then you can do the mechanical method by giving a bimanual compression or mask technique. Or if not, then you can do the surgical, along with the B-Lynch sutures, you can do the surgical management, or you can do the uterine artery ligation or internal iliac artery ligation. If that is also not working, then hysterectomy is the possible treatment of choice. For traumatic, ligation and tear management is the primary choice. Okay, cervical tear, most common location is. Cervical tear, most common location is 3 o'clock position. What maneuver we use to prevent the perineal tear? What maneuver we use to prevent the perineal tear? Ridge-and maneuver. What maneuver we use to prevent the perineal tear, people? Ridge-and maneuver we uses. Next is a uterine inversion, inside out turning of your uterus. Management is resuscitation and replacement. Replacement by manual, you can do the like a hydrostatic, O'Sullivan method, or Johnson's maneuver you can use. Johnson's maneuver is the manual replacement of your uterine inversion. And if there is a surgical intervention, if it is a vaginal surgery, Spinelli or Kushner method we uses. If it is a abdominal, Huntington, Robinson or Halton method we uses. Huntington, Robinson or Halton method we uses for abdominal. For vaginal, Spinelli or Kushner method we uses. For manual, we can do the Johnson's maneuver, or hydrostatic O'Sullivan method we can use it. So remember one thing, a shock patient immediately after delivery, it is definitely uterine inversion. That's the question. Any patient who is hemodynamically compromising immediately after the delivery, then most common choice could be the uterine inversion, people. Uterine inversion could be the most common choice, where you may see there is a inside out turning of your uterus, and you have to manage it by the resuscitation and replacement. Very classical MCQ or classical clue. Okay, shock features immediately after the delivery. For example, increase in heart rate, decrease in blood pressure, cold extremities, blah blah blah. If they are given you this immediately, hemodynamic compromise after the delivery, immediately after delivery, it should be there. Okay, then it is a uterine inversion. Okay, then placenta accreta, morbidly adherent uterine wall, morbidly adherent placenta to the uterine wall due to the lack of decidua basalis and Nitabusch membrane. As I said, Nitabusch membrane is absent in percreta, increta, and accreta. Yes or no? We are having a 3 types. As I said, accreta, increta, and percreta. Percreta is myometrium plus serosal involvement. Accreta is attachment at the superficial myometrium. while increta is attachment at deep myometrium. Okay, increta is attachment to deep. Accreta superficial, increta deep, percreta myometrium plus serosal involvement. Most common risk factor present during the pregnancy. Diagnosis is made by TVS, where you see the absence of subplacental sonolucent zone. Where you see the absence of subplacental sonolucent zone is seen in the TVS, and Doppler showed less than 1 mm of distance between uterine serosa and retroplacental vessels. Another important one, MRI showed a uterine bulging, placenta accreta. Management, total placenta accreta. If the patient has completed the family, then do the C-section and hysterectomy. If the patient has not completed family, then do the conservative management. Okay, if the patient want to have more kids, do the conservative management. If the patient had finished the family, then do the C-section and take out the baby, and then you can do the hysterectomy. Okay, so placenta, accreta, increta, percreta. Accreta, attachment at superficial myometrium. Increta, deep myometrium. Percreta, myometrium with the serosal involvement. Okay, diagnosis, 3 things. Transvaginal ultrasonography, Doppler, MRI. Transvaginal ultrasonography shows absence of subplacental sonolucent zone. Okay, absence of subplacental sonolucent zone. And Doppler showed large intraplacental legs. And management, completed family, C-section plus hysterectomy. Incompleted family, or the family want to continue, then you do the conservative management. Then you have amniotic fluid embolism, rare, which is a very, very rare. And the criteria, acute hypotension or cardiac arrest, followed by acute hypoxia, followed by coagulopathy or severe hemorrhage, which is occur during the labor or C-section or dilation or evacuation within the 30 minutes of postpartum. Okay, within the 30 minutes of postpartum. The sudden onset of collapse plus tachypnea plus cyanosis plus hypotension plus DIC plus altered mental status. This many features. Sudden onset of collapse, tachypnea, cyanosis, hypotension, DIC, altered mental status. While the postmortem finding, amniotic fluid and pulmonary vessels will be there. Amniotic fluid and pulmonary vessels will be there. Mostly AFE cannot be treated. Mostly 90% scenario patient dies in the AFE. AFE. Okay, next is a pain management. Pudendal nerve block. Pudendal nerve S2, S3, S4 can be blocked just above the tip of your ischial spine. And a paracervical block, 5 to 10 ml of 1% lignocaine will be injected on 4 to 6 o'clock and 6 to 8 o'clock position. Epidural block, T10 to S5 dermatomes will be blocked. C-section from T4 and contraindicated in maternal coagulopathy, supine hypotension, hypovolemia, neurological diseases, low back ache, thrombocytopenia, low molecular weight apparent with the within a 12 hours of labor, untreated bacteremia, and increase in intracranial pressure. Increase in intracranial pressure are the contraindications of your epidural block. Then induction of labor assessed by Bishop score. Components of Bishop score was very, 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 very important. Asked in several times in FMGE. So you have to know Bishop score. The components are dilatation, position, and effacement of cervix. I used to say, remember with the mnemonic of, a deep pec cervix with the head station. Deep pec cervix with the head station. Cervical dilatation, cervical position, effacement, and consistency. Okay, deep pec cervix with a head station. Cervix with head station. Okay, cervical dilatation, position, effacement, head station, and cervical consistency. In the modified Bishop score, instead of effacement, they use as a length. Okay, instead of effacement, they use as a length, and successful Bishop score would be score of more than 9. Successful Bishop score would be the score of more than 9. Okay, what are the methods? We have the induction of labor. First one is your mesoprostal, oral 100 mcg or vaginal 25 mcg you can give, or you can give a uterotonics 10 to 12 ml per microliters by infusion. And apart from that, artificial rupture of membrane using a Feautres forceps, artificial rupture of membrane using a Feautres forceps can be used. Apart from that, you know the Ferguson reflex, where you put a compression, you put a pressure on the cervix, uterine will contract. That is a Ferguson reflex, which is contraindicated in severe degree of contracted pelvis, cancer cervix, cord prolapse, malpresentation, genital herpes and placenta previa. Genital herpes and placenta previa. What are the components of Bishop score, people? What are the components of Bishop score? As I said, deep X service with head station, cervical dilatation, cervical position, effacement, consistency, and head station. And how much should be the minimum? If it is more than 9, then consider it successful. Then consider it successful. Then apart from that malposition, most common position is occipito-posterior position. Most common position is occipito-posterior position, where occiput lies on the sacroiliac joint. If it is on the right, right occipito. If it is on the left, left occipito-posterior. Most common cause of malposition is the occipito-posterior position. Most common causes android or anthropoid pelvis. Okay, android or anthropoid pelvis. And mostly associated with the nulliparous women, people. Mostly associated with the nulliparous. So what are malposition? Any position of vertex other than the flexed occipito anterior or occipito transverse position is so called as malposition. Most common position is OPP, associated with the android and anthropoid pelvis, nulliparous. Most common cause of non-engagement of head and term in primigravida. Non-engagement of head and term in primigravida is malposition. Management, if it is a favorable condition, do the normal delivery. If it is an unfavorable condition, look for the 3 things. If either the arrest is on the deep transverse arrest or oblique posterior arrest or deep sacral arrest. Deep sacral arrest, do the C-section. For oblique posterior, then if you look for the OPP, if it is a persistent OPP, then phase 2 pubes delivery will be the option. Okay. If it is a deep transverse arrest, C-section or venous delivery will be there. Or you can do manual rotation of head with the Keylands forceps. Manual rotation of head with the Keylands forceps you can do for the deep transverse arrest. Either a C-section or a venous delivery or manual rotation of the head using a Keyland forceps for the deep transverse arrest. Oblique posterior, which is a persistent OPB, most common in anthropoid pelvis, where you can do the phase 2 pubes delivery. Deep sacral management is management of option is C-section. So what is the most common malposition, people? Most common malposition is OPP. Most common causes android and anthropoid pelvis. So unfavorable deep transverse arrest, management of choices, C-section or venous delivery or rotation of head using what forceps, people? Rotation of head using Keyland forceps. Rotation of head using Keyland forceps. While here, what forceps are we using? While here, what forceps are we using? In the case of your management of your this one, you know, in the case of your management of your what do we call it? Management of your hematoma. Phrygian maneuver we uses. Phrygian maneuver we uses, and manual rotation of head for the deep transverse arrest, Keyland forceps we uses. Okay. Apart from that, malpresentation, any presentation other than the vertex is a malpresentation. If we are having a phase, bro, and a breach, breach is the most common, where the lie is longitudinal here, and types could be complete breach or extended breach or knee presentation or footling presentation. Complete breach or extended breach or knee presentation or footling presentation will be there. And bro presentation, diagnosis will be pervaginal by palpating a supraorbital ridges and anterior fontanelle. Delivery C-section. For face presentation, Most common cause is anencephaly. Most common pelvis is platyploid. Most common position is left mento-anterior position. LMA, anencephaly, platyploid, extension attitude. Mento-anterior, look for the measurement. It should be submento-pragmatic or submento-vertical, then go for C-section. If it is a mento-posterior, wait and watch. If it is detected in late labor, then do the C-section. So wait and watch for mento-posterior, and you can able to do the C-section for mento-anterior. If the mento-posterior late detected, then you can do the C-section. Clear, people? Then management of breech, baby more than 7 week, ECV, contraindicated in placenta previa and multifetal pregnancy, and vaginal delivery in breech, yes, if Zachuni-Andro score is more than 4. Okay, if Zatochny-Andro score is more than 4, then you can do the vaginal delivery in breech. Okay, then you can do the vaginal delivery in breech, and you have to avoid the induction of labor and rupture of membrane. Okay, then delivery part, buttock engaging diameter is bitrochanteric diameter, where you see the groin traction or pinard maneuver. Okay, pinard maneuver is used for buttock presentation. Love-set maneuver is used for shoulder presentation. And after coming head, Burn Marshall technique or Bracht maneuver or Maricos-Smelly weight technique, Weigand-Martek technique or forceps delivery you can do along with the Neville-Barney Pipers or Neville-Barney forceps or DAS forceps. Piper's forceps, Neville-Barney forceps or DAS forceps or Weigand-Martek technique, Weigand-Martin technique, Maricos-Smelly welt technique, Bracht maneuver, Burn Marshall technique for after coming head, Love-set maneuver for shoulder, and Pinard maneuver and groin traction is for buttock. Groin traction is for buttock. Okay, apart from that, you can do the C-section for footling presentation or stargazer breech, or twin with the first breech, or breech score is less than 3. You can do the emergency C-section if there is a prolonged first and second stage, along with the cord prolapse or footling or knee detected at the labor. That's the time you can do the emergency C-section. Okay, so buttock presentation, Pinard maneuver, and shoulder presentation, Love-set maneuver, Burn Marshall technique or Bracht maneuver or Maricos-Smelly welt technique or Weigand-Martek technique. Then it is a after coming head, Neville-Barney forceps or Piper's forceps. Then after coming head, the diameter engaging for buttock bitrochanteric, for shoulder bisacromial, or after coming head, suboccipitofrontal diameter. Okay, bisacromial is for shoulder, suboccipitofrontal is for after coming head, bitrochanteric diameter is for buttock presentation. Okay, buttock presentation. Apart from that, you have a transverse lie. Presenting part is a shoulder. Most common cause of transverse lie is prematurity, people. Most common cause of transverse lie is prematurity. And transverse lie diagnosis, fundal height is less than the period of amenorrhea. And a gridiron feel will be there in the pervaginal examination, and management is C-section for transverse lie. And for unstable lie, the most common management is elective C-section, and the most common cause of fetal death in unstable lie is cord prolapse. Very, 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 very important MCQ is cord prolapse. Okay, then you have an operative obstetrics, forceps versus vacuum delivery. Forceps traction pressure for primi 20 kgs, for multi 13 kgs. Absolute contraindication, CPD, cephalopelvic disproportion, contracted pelvis, HIV positive female, osteogenesis imperfecta, or history of coagulopathy. Most common complication is perineal tear. Maximum attempt is 3. If undelivered, failed forceps delivery will be there. And forceps highlight, outlet forceps used in India are Wrigley's. Mid-cavity forceps are seen in Das or Neville's. And to rotate the fetal head, Kaylan's and Barton forceps. And delivery of aftercoming head, then it is a Piper's forceps. So we have already known about the forceps. Wrigley's, outlet forceps used in India. Das or Neville's forceps, Neville-Barney, mid-cavity forceps. Kayland or Barton to rotate the fetal head. and Piper's forceps, delivery of after coming head. Delivery of after coming head. Then you have a vacuum delivery. Pressure, initial pressure on the vacuum is 0.2 kg per centimeter square. Maximum is 0.8 kg per centimeter square. Location of application, 3 centimeter anterior to posterior fontanelle or 6 centimeter posterior to anterior fontanelle. Okay, either 3 centimeter anterior to posterior fontanelle or 6 centimeter posterior to anterior fontanelle. Okay, and maximum attempts of vacuum delivery, 3. Okay, and for first choice in occipital anterior, you do the 6 centimeter cup size, and best for OPP, you do the 5 centimeter cup size one. You do the 5 centimeter cup size one. Apart from that, episiotomy type is median, mediolateral, lateral, and J-shaped episiotomy are there. Median one will cause a perineal tear, while the mediolateral one, where the structures cut, will be posterior vaginal wall, perineal muscle, bulbocavernous, levator ani, transverse perineal branches of your pudendal nerve and vessels, skin and subcutaneous tissue are the one which cuts on the mediolateral episiotomy. Okay, ideal time before the crowning you have to do. Ideal time before the crowning, you have to do the episiotomy. Then you have a C-section. What type of incision you can do for the C-section? Fennelstein incision or Joel-Cohen incision you can do for the C-section. Absolute indication is CPD, broad ligament fibroid, vaginal atresia, cancer cervix, and central placenta previa. And central placenta previa. And level of anesthetics is T4 in terms of your C-section. And the time for next pregnancy, ideal waiting time is 18 months, minimum 6 months. Ideal waiting time is 18 months, while the minimal waiting time is 6 months. Uterine rupture is more common in USCS over the LSCS. Okay, uterine rupture is most common in USCS over the LSCS. Ideal waiting time is 18 months. Level of anesthesia is T4. Absolute indication is CPD, broad ligament fibroid, cancer cervix, vaginal atresia, central placenta previa. Types of incision, Fennelstein incision and Joel-Cohen incision you do for the C-section. Okay, episiotomy, 4 types. Most common variety are median and mediolateral. Median can cause a perineal tear. Mediolateral, the structures cut we have discussed. Ideal time before crowning. Ideal time before crowning. Okay, and when do you do the vacuum delivery? What is the exact location? 3 centimeter anterior to posterior fontanelle or 6 centimeter posterior to anterior fontanelle. Maximum attempt is 3. 5 centimeter cup size is the best for occipito-posterior position. Then forceps, types of forceps. Outlet forceps used in India are Wrigley's forceps. Mid-cavity forceps in India are Das or Neville forceps. To rotate a fetal head, Keeland or Barton forceps. And delivery of aftercoming head, Piper's forceps we use as. And that to maximum of attempt 3. Okay, that to maximum attempt is 3. Most common complication is perineal tear. And traction pressure for primi is 20 kg, for multi is 13 kg. Okay, multi is 13 kgs. Okay, clear about the operative obstetrics. We have talked about the forceps delivery, vacuum delivery, episiotomy, C-section. And we have talked about the, malpresentation, malpositions. And now we are going to talk about the ectopic pregnancy and abortion people. Ectopic pregnancy and abortion. So shall we proceed to the ectopic pregnancy and abortion? Speaking about the ectopic pregnancy and abortion, what is the ectopic pregnancy? A state of having an implantation of product of concept in the site other than the normal site. Okay. Implantation the product of concept is in the site other than the normal site is so called as your ectopic pregnancy. Most common site is your ampulla. Okay, most common site is your isthmus is the most common site for tubal rupture, and most common site for tubal abortion is your ampulla, and interstitium is the least common site, and infundibulum is the another area where you can see. So ampulla, most common site for tubal abortion, most common site for tubal rupture is isthmus, and least common site in the fallopian tube is interstitium. Least common site overall is your C-section scar. C-section scar. Okay, that's the least common site overall for the ectopic pregnancy. What is ectopic pregnancy? Site other than the normal site. Okay, site other than the normal site. So how do you diagnose the ectopic pregnancy, people? Any woman of reproductive age, women of reproductive age with amenorrhea, with amenorrhea and pregnancy symptoms presents to you. You do the test and you do the physical examination. You do the physical examination, you do the lab, and you do the radiological examination. Okay, three things you may do. The physical examination, uterus small for GA, uterus small for gestational age, and small for GA, or you may see there is a tender adnexal mass on bimanual, tender adnexal mass on bimanual, bimanual, sometimes bleeding from cervix. Sometimes bleeding from cervix will be there. Okay, you do the physical examination, then you do the lab, you do the BCG or beta HCG. Beta HCG was positive. Beta HCG was positive, but not doubling in 48 hours. Classical one. Not doubling in 48 hours, or low for pregnancy, or low for normal gestational age. Then it is the lab one, and the radiological USG shows adnexal mass are extrauterine cell mass or extrauterine pregnancy detected. Extrauterine pregnancy detected. Then it is a ectopic pregnancy, people. Okay, any reproductive female presents to you with the amenorrhea and pregnancy symptoms, on physical examination, uterine small for the gestational age, tender adnexal mass on the bimanual, and bleeding from the cervix occasional. Then you do the lab test. The classical one, if they want to check you with the, if they want to test you with the ectopic pregnancy, this is the classical one. The beta HCG is either not doubling in 48 hours, or the beta HCG is small for your gestational age, or the beta HCG is small for the gestational age. Then that is a routine, then that is a classical vineyard which is directing you to the ectopic pregnancy. Okay, most common site is your fallopian tube, and tubal rupture ampulla, tubal rupture isthmus, tubal abortion is ampulla. Then for a ruptured stable one, exploratory laparotomy you do. Ruptured unstable one, first to stabilize them and then do the laparotomy. For an unruptured one, do the laparoscopy instead of laparoscopy for the surgical one. And for a medical one, give him a methotrexate or the, like a prostaglandin analog 50 mg. Then you can able to sort it out. What are the named criteria we have for the, like ectopic pregnancy was Studyford criteria, Spiegelberg's criteria, and Rubin-Pohlmann-McLean's criteria. Okay, Rubin's are Pohlmann-McLean's criteria for cervical, Spiegelberg criteria for ovarian, and Studyford criteria for abdominal pregnancy. Studyford criteria for abdominal pregnancy you are having. Okay, clear about that? If the patient is having a history of 1 prior ectopic pregnancy, then 10%, then 2 prior ectopic pregnancy, it is 25%. Remember that. Okay, 1 prior ectopic 10%, 2 prior ectopic 20%. Important cause is your smokers. Okay, important cause is your smokers. These are the important ones. Studyford criteria, Spiegelberg criteria, or Rubin or Pohlmann-McLean criteria for the cervical or ovarian or abdominal pregnancy. Okay, these are the important things. Apart from that, abortion, spontaneous termination of pregnancy before fetal viability, or 28 weeks. Before fetal viability are 28 weeks. Spontaneous abortion, pregnancy loss less than 20 weeks. WHO definition, expulsion of fetus which is less than 500 grams is so-called as abortion. Most common cause of spontaneous miscarriage, very, 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 very important MCQ. What is the most common cause of your spontaneous miscarriage? Chromosomal anomaly. Most common cause is that too, aneuploidy over trisomy 16. Most common cause is aneuploidy, and if it is a they are asking you most common trisomy associated with the spontaneous miscarriage, then it is a trisomy 16. Then it is a trisomy 16. And then you have a classification, spontaneous or induced one. So, and apart from that, you may have a different types of abortion. So first one is threatened abortion associated with the retroplacental hemorrhage. So 6 week plus bleeding PV plus uterine size match, then that is a threatened abortion. Recurrent abortion, most common causes chromosomal anomalies and a sequence of 3 or more spontaneous abortion before 20 weeks. Recurrent abortion means chromosomal anomalies is the most common cause. Sequence of 3 or more spontaneous abortion before 20 weeks. Okay, 3 or more spontaneous abortion before 20 weeks. Primary means no successful delivery. Secondary means at least one successful previous pregnancy. Most common cause of second trimester recurrent abortion, cervical incompetence. Very, 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 very classical MCQ people. Most common cause of second trimester recurrent abortion is cervical incompetence. And apart from that, incomplete one, amenorrhea plus passage of fetus of conception plus bleeding PV. Amenorrhea, fetus conception passage plus bleeding PV is incomplete. Uterine sizes less than the period of amenorrhea. Uterine sizes less than the period of amenorrhea. Complete, no presence of fetus where you see the empty uterus. And for a missed one, dirty brown discharge, uterine sizes less than the period of amenorrhea. Closed cervical os you may see. Closed cervical os you may see. Apart from that septic one, purulent vaginal discharge with the foul smelling and sepsis. Purulent vaginal discharge with the foul smelling and sepsis are the common one. You may see it along with the case of your abortion. So abortion, these are the important highlights of abortion. Spontaneous of termination of pregnancy before the period of viability is abortion. And most common cause of, like expulsion of fetus less than 500 gram is the abortion definition as per the WHO. And most common cause of spontaneous miscarriages, chromosomal anomaly. Most common cause of second trimester recurrent abortion is cervical incompetency. Recurrent abortion means primary is no previous successful pregnancy. Secondary is at least one single successful pregnancy. Most common cause of recurrent abortion is chromosomal anomaly. That too aneuploidy over trisomy. Most common trisomy is also trisomy 16. Trisomy 16. Incomplete means uterine size is less than the period of amenorrhea. You see the passage of fetus of conception. Complete means no presence of conception material. That is an empty uterus. Missed means the dirty brown discharge you may see. Septic is purulent vaginal discharge with the foul smelling you may see. Dirty brown discharge, missed abortion. Foul smelling discharge, septic abortion. Empty uterus, complete abortion. And you may see there is a amenorrhea plus bleeding PV plus passage of fetus of conception, incomplete abortion. Retroplacental hemorrhage, which is a, like a threatened abortion. Okay, cleared that? Cleared about the abortion, people? Very, 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 very important topic. Okay, this is also one of the topic where you need to see 1 hour before the exam. 1 hour before the exam. Okay, you should not miss it. Then MTP Act, as per the MTP Act, termination done in the government hospital or government recognized hospital, consent of women is required normally. If it is a minor, then guardian's written consent is also required. Consent of women is required. If it is a minor, then the guardian's written consent is also required. No role of the husband here. Remember, if the husband want to abort, there is no role of the husband here. Okay, you should follow only the women's decision. You should follow only the women's decision. If it is the period of 12 to 20 weeks, then 2 doctors' approval is required. We studied that MTP Act and the PSM also. Apart from that, the regimen till 7 weeks, day 1, mifepristone 200 mg oral, and 7 to 9 weeks, then day 1, you have to do the mifepristone 200 mg oral. Okay. Apart from that, day 3, you have the dose misoprostol 400 mcg, 3 hours of observatory periods, and the next visit will be after 2 weeks. Then by the third day, vaginal misoprostol of 800 mg you may do for 7 to 9 weeks. And for day 15, check for the complete evacuation on the after 2 weeks. So till 7 weeks, mifepristone 200 mg oral, and after 2 days you have to come misoprostol 400 mcg, 3 hours of observation. Here, this is the thing is same, except for 7 to 9 weeks. By the third day, you have to give a vaginal misoprost of 800 mcg. You have to give. That's the only difference. Okay, medical termination, best method is less than 7 weeks. For 7 to 12 weeks, best method is suction and evacuation. More than 12 weeks, prostaglandin analog is the best method. Okay, then twin pregnancy, dichorionic twin peak sign or lambda sign you may see. TTTs is associated with the monochorionic placenta. Management, first and second twin is cephalic, then do the both vaginal deliveries. First is cephalic and second is longitudinal, vaginal followed by C-section. First is cephalic and second is transverse, then vaginal delivery followed by internal podalic version. Make it a breech and breech extraction. Okay. Then you have a placenta previa, Brownies classification you have. Type 1 is lateral, type 2 is marginal, type 3 is incomplete central, type 4 is central. Major degree placenta previa is type 3 and 4, and dangerous type is type 2 posterior. Very important. Dangerous type of placenta previa is type 2 posterior. Absence of vaginal examination, while the regimen we uses here, another important MCQ, McAfee and Johnson's regimen. McAfee and Johnson's regimen is used for placenta previa. And apart from that, abruptio placentae, most common type is your mixed type. For the abruptio placentae, most common type is your mixed type. Then what are the diseases in pregnancy? First one is the diabetes in pregnancy. The highlights were most common system involved is cardiovascular. Most common congenital anomaly is VSD. Most specific is caudal regression syndrome. Most specific cardiac anomaly is transposition of great vessel. Pretty straight question, people. Pretty straight one-liners. You should not miss. Most common system is CVS. Most common congenital anomaly is VSD. Most specific is caudal regression syndrome, and most specific cardiac is transposition of greater vessels. Fetal complication, hypoglycemia and macrosomia is the fetal complication. Apart from that, hypertension, more than 20 weeks plus hypertension, gestational hypertension. More than 20 weeks plus hypertension plus proteinuria, preeclampsia. Less than 20 weeks plus hypertension after delivery, chronic hypertension. Okay, heart disease. Most common heart disease is rheumatic heart disease. Most common lesion is mitral stenosis, which is contraindicated in pregnancy, was Asian-Mager anomaly and primary pulmonary hypertension, Marfan's disease, and severe AS. Okay, what stage of labor to be reduced in the pregnancy? That is your second stage in terms of your heart disease. Okay, second stage in terms of your heart disease. Okay, these are the important highlights of the diseases of your pregnancy, and these are the important highlights in the obstetrics, people, completely. So here are some image-based question. One is your mediolateral episiotomy and episiotomy incision image. Apart from that, this one is a hydatiform mole image. Hydatiform mole image. Uterine prolapse. Uterine prolapse. Amniocentesis. And tubal ligation, where you see the ligation of tubes was made, and vacuum extraction or Bento's delivery, we used to call that as. And apart from that, you have this uterine fibroid, which we discussed in the this in the gynecology. Placenta previa. Placenta previa. What is the most dangerous type of placenta previa? What is the most dangerous type of placenta pravia, people? Type 2 posterior. Yes or no? Type 2 posterior. Then twin pregnancy, dichorionic diamniotic twin placenta. And apart from that, you have a perineum and mastitis and imperforate hymen. Imperforate hymen, we will discuss that in the gynecology. And apart from that, you have the ruptured ectopic pregnancy where you see the Cullen and Gray Turner sign, and you see the choriocarcinoma. Then these are the important instrument: Hagar's dilator, ovum holding forceps, episiotomy scissors, and Wolfram forceps, and Cusco's vaginal self-retaining speculum, and uterine curate. Uterine curate. These are the important one. This is a episiotomy, and uterine anomalies. We discussed that later. And Leopold maneuver. This is an image of your Leopold maneuver, where the fundal palpation, lateral palpation, and pollic grip and pelvic palpation are the 4 steps of your Leopold maneuver. One of the classical image they asked in a NEET PG. Till now they haven't asked in FMGE, but they asked in a NEET PG. Okay. Then triple screening and quadruple screening done for the Down syndrome. Triple screening is beta HCG, AFP, and estriol. While quadruple, adding inhibin A on the triple, you make a quadruple screening. Okay, then trichomonas infection. Trichomonas infection image. So these are the important images. You may see it in the obstetrics. These are the important images. You may see it in the obstetrics. Leopold maneuver. Leopold maneuver. Instruments, especially the Cusco's vaginal speculum, and Cullen sign and Gray Turner sign, and Ventos delivery for mastitis, imperforate hymen, placenta pravia, and uterine prolapse, amniocentesis, tubal ligation are the important images they may ask you in a FMGE, people. They may ask you in a FMGE. Okay. Anyway, take a 5 minutes of break and take a 10 minutes of break. Come back by 10:10. We will do the gynecology. Today we are finishing the gynecology, people. Okay, take a 10 minutes of break and come back after 10 minutes. So see you by 10:10. We are moving on to the gynecology. Okay, we are resuming the next session. So the next session is your gynecology. Quite easy. The important highlights has been mentioned here on the point-wise people. Okay, the important highlights were mentioned as a point-wise, where you have to answer most of the question, the straightforward questions in the gynecology. So quite important one. Listen here, very easy one. Okay. So speaking of a menstrual cycle, so we are having the two important phases of your menstrual cycle. One is your follicular phase, and another one is your luteal phase, people. Follicular phase, and another one is your luteal phase. So speaking of a follicular phase, speaking about the follicular phase, which is from 1 to 14. Follicular phase will start from 1 to 14, and the luteal phase will start from 14 to 27. And follicular phase is a estrogen dominant one, where you see the follicular development, while the luteal phase is a progesterone dominant one, where you see the corpus luteum development and degeneration. Corpus luteum development and degeneration. So what are the important highlights which we have seen in the menstrual cycle? So LH surge occurs 24 to 36 hours prior to ovulation. Very classical MCQ, people. LH surge occurs 24 to 36 hours prior to ovulation, and LH peak occurs 10 to 12 hours prior to ovulation. Okay, LH peak occurs 10 to 12 hours prior to your ovulation. 4 to 36 hours. LH peak occurs 10 to 12 hours prior to ovulation, and a hormone responsible for LH surge is your estrogen. Hormone responsible for LH surge is your estrogen, and a day of ovulation is equal to number of cycle days by 14, because this was asked in FMGE several times long back. Like, for example, women with the 32 days of cycle, women with the 32 days of cycle, then what is the day of ovulation in this patient? What is the day of ovulation in this patient? Or they may say you that there is a young couple who came to you for the reproductive counseling, and you assume that women says like there is a 38 days of your normal cycle. Her normal cycle was about 32 days, and she is asking about the ideal time for the sexual interaction. So what is the ideal time, they may ask you. Okay, so cycle days minus 14. For example, in this scenario, 32 minus 14. What is the day of ovulation here? Or ideal time to have a sexual intercourse? That is a 32 minus 14, which is your, technically speaking, 18th day, which is technically speaking 18th day. Okay, or the progesterone reaches peak and corpus luteal cycle size will reach a peak by day 22 of your cycle. Okay, day of ovulation is cycle days minus 14. Hormone responsible for LH surge is estrogen. LH peak 10 to 12 hours prior to ovulation. LH surge 24 to 36 hours prior to ovulation. Progesterone reaches highest and corpus luteal size will reaches highest by day 22 of your cycle. And abdominal pain during a ovulation is so called as Mittel-Schemers syndrome. Mittel-Schemers syndrome is the abdominal pain during a ovulation, not during the menstruation. You should remember that. Okay, abdominal pain during ovulation is Mittel-Schemers syndrome. Then, so menstruation, so primary amenorrhea and secondary amenorrhea. So what is a primary amenorrhea? A person who never had a menstruation before is so called as primary amenorrhea. So UPT, urinary pregnancy test you do, obviously it comes as negative because the patient is in the primary amenorrhea. Then check for the secondary sexual characteristics, people. Then check for the secondary sexual characteristics. If the secondary sexual characteristics are normal, then look at the uterus. If the uterus is there, then it is due to either a hormonal imbalance like LH, FSH, TSH, or PRL anomalies, or if there is an anatomical anomaly like a cervical atresia, a transverse vaginal sputum, or imperforate hymen, So imperforate hymen, they may ask you this typical question. The patient, 18-year-old female patient with the primary amenorrhea comes to you with the history of pain on every 28 days, and there is no bleeding, and on examination showed there is a bluish discoloration on the hymen. Specify the diagnosis. Typically, it is a imperforate hymen. Typically, it is a case of imperforate hymen. Mostly, imperforate hymen would be asked as a clinical vignette. Okay, clinical vignette. And for negative, it is a MRKH syndrome. If there is no uterus, then it is a MRKH syndrome. And look at the secondary sexual characteristics are absent. Look for the FSH and LH. If the FSH and LH are more, then either a primary ovarian failure or Turner syndrome or galactosemia. If it is less than that, then it is a Kallmann syndrome. Okay. Then next is a secondary amenorrhea. Most common cause is your pregnancy. Secondary amenorrhea is pregnancy. What is the secondary amenorrhea? Patient previously had a menstruation. All of a sudden, the menstruation has not been occurring. Okay. Then UPT positive pregnancy. UPT negative. Then look for the periods. Cycle. If the cycles are improper, then PCOD. If the patient are not having any period at all, then there might be three causes. Either a ovarian failure, or it may be Sheehan's, where the BMR decreases, alopecia, and there is a heat thyroid pattern you will be seeing, and there is a decrease in BP. All of those things you may see. And apart from that, there is a Asherman syndrome, oligomenorrhea, while the treatment is adhesiolysis. So no period, Asherman, Sheehan's, or ovarian failure. If there is an improper period, then PCOD. What type of findings you may see it in the ultrasound? Necklace pattern, obese, oligomenorrhea, alopecia with the hirsutism. Okay, necklace pattern, obese, oligomenorrhea, alopecia with the hirsutism. The alopecia pattern would be of a male pattern. Male pattern alopecia will be there. Apart from that, abnormal uterine bleeding, polymenorrhea. What is a polymenorrhea? Menses within 21 days. With less than 21 days, it is polymenorrhea. Oligomenorrhea, menses with more than 35 days. And hypomenorrhea, less than 2 days of bleeding is hypomenorrhea. Menorrhagia, more than 7 days of bleeding. And menometrorrhagia, excessive bleeding at irregular intervals. Excessive bleeding at irregular intervals is menometrorrhagia. Menorrhagia means more than 7 days of bleeding, and hypomenorrhea means less than 2 days of bleeding. Oligomenorrhea means menses with more than 35 days. Polymenorrhea means menses with less than 21 days. Then palm coin of your AUB, where the causes of abnormal uterine bleeding has been coined as palm coin. P stands for polyp, A stands for adenomyosis, L stands for leiomyoma, M stands for malignancy. Palm. Coin. C stands for coagulopathy, O stands for ovarian dysfunction, E stands for endometrial dysfunction, I stands for iatrogenic, and N stands for non-classified one. These are the palm coin of your abnormal uterine bleed. So management, if it is a surgery, then do the endometrial ablation therapy. Medical management, mostly for the mild to moderate, tranexamic acid along with the OCPs will do the sufficient thing. If it is a severe, look for the vitals. If the vitals are stable, patient is less than 45 years, then do the USG for the endometrial thickening. If there is an endometrium is thickened, then do the OCPs. If the endometrium is thin, then do the high dose estrogen followed by OCP. Okay. If it is more than 45 years, then you do the endometrial biopsy. biopsy. If the patient is vitals are unstable, then DNC. Okay, DNC over the IV estrogen, then the OCPs. Okay, so management of AUB, surgical endometrial ablation, medical for mild to moderate tranexamic acid along with the OCPs. If it is a severe, check for the vitals. Vitals are stable or vitals are unstable. Vitals unstable, do the DNC followed by IV estrogen, then OCP. If it is a vitals are stable, then look at the patient age, more than 45 with the abnormal uterine bleeding, do the biopsy. Okay, do the biopsy to rule out the endometrial hyperplasia or any cancer. If it is less than 45 years, then do the USG to look for the endometrial thickening. If it is thickened, then give the OCP. If it is thin, then do the high dose estrogen followed by the OCPs. High dose estrogen followed by OCPs. Then you have a menopause. Permanent absence of menstruation for 9 years is so called as menopause. Permanent absence of menstruation for 9 years is so called as menopause. Premature menopause is less than 40 years. Delayed menopause is more than 55 years. Delayed menopause is more than 55 years. While the hormonal change, low estrogen, increased FSH and LH. So you may see the HMG in urine. You may see the HMG in urine. And because of the lack of estrogen, you have the osteoprotein protein will be decreased. And whenever there is a osteoprotein protein is decreased, then there will be an activation of rank L ligand. Rank L ligand we studied in vitamin D deficiency. What does the rank L ligand will do? Activation of or the conversion of pre-osteoclast to osteoclast. Yes or no? So rank L ligand is activated. Osteoclast will be activated. Osteoporosis will be there. Okay, that's why in the postmenopausal women, you see the osteoporosis or bone disorder. Apart from that, patient may have a hot flashes, sleep disorder, cognitive disorder, depression, wrinkling of skin. Everything will be there in the menopause. And treatment of choices, hormone replacement therapy. Okay, HRT, and then followed by uterus. If the uterus is there, then the estrogen and the progesterone. If the uterus is negative, then only the estrogen. Then only the estrogen is the treatment of choice in terms of your menopause. What is menopause? Permanent absence of menstruation for almost 9 years. Premature, less than 40. Mature, more than 55 years. Okay. And apart from that hormonal change, low estrogen, high FSH and LH. Low estrogen, osteoprotein protein will be low. Rank L ligand will be activated. More rank L ligand, osteoclast will be activated. Osteoporosis will be there. Hot flashes, sleep disorder, wrinkling of skin and emotional things will be there. The treatment of choices, HRT. Then postmenopausal bleeding, most common causes endometrial atrophy and senile endometriosis. Okay, endometrial atrophy and senile endometriosis. Primary investigation is TVS to look for the endometrial thickness. If the endometrial thickness is more than 5, investigation of choices endometrial sampling. Endometrial sampling. While the gold standard treatment of choice is fractional curettage plus hysteroscopy. Okay, fractional curettage plus hysteroscopy over the DNC along with the hysteroscopy. So the main treatment gold standard is fractional curettage for postmenopausal bleeding. First investigation is TVS to look for the endometrial thickness. If it is more than 5 mm of thick, endometrial sampling should be taken. Okay. Most common cause of endometrial bleeding is endometrial atrophy and senile endometriosis. So we talked about the menstruation, we talked about the menopause. Now speaking about the puberty, what is a puberty? Development of secondary sexual characteristics in males and female is so called as puberty. First sign of puberty in female is growth spurt, while the first sign of male puberty in male is testicular enlargement. Testicular enlargement. So what is a precocious puberty? Male less than 9 years and female less than 8 years. Delayed puberty, non-development of secondary sexual characteristics in females of less than 30 and in males of 12 years. Okay. Precocious puberty, central is premature activation of HPO axis. Most common causes idiopathic, while peripheral precocious, exogenous production of estrogen or androgen. Androgen, tumors and CAH, congenital adrenal hyperplasia will be the cause, While estrogen, again tumor, granulosa cell tumor, hypothyroidism, and McCune-Albright syndrome will be the cause. McCune-Albright syndrome will be the cause. What is the triad of symptoms? You may see it in the McCune-Albright syndrome. You see cafe all spot, polyostotic fibrous dysplasia, along with the precocious puberty. So what is the triad of McCune-Albright? You see the cafe all spot, precocious puberty, polyostotic fibrous dysplasia. Polyostotic fibrous dysplasia can form a McCune-Albright syndrome. Okay. Apart from that, this is all about the menstruation, normal and abnormal. We have talked about the menstruation, uterine bleeding, terminologies, menopause, and puberty, and their respective causes and associated pathologies we have discussed. Now we are going to talk about the infections in gynecology. Vaginitis based upon the discharge, greenish yellow, trichomonas vaginalis, curdy white, candidiasis, gray color, bacterial vaginosis. So what are the things you have to remember in terms of your vaginal discharge? Bacterial vaginosis, Gardnerella vaginalis is an organism where you see the clue cell alkaline pH. Clue cell and alkaline pH. While candidiasis, pseudo hyphae in KOH mount, sheikh kebab appearance. Sheikh kebab appearance. While you may see there is a drug of choices, fluconazole and pruritus you may also see. And trichomonas vaginalis, strawberry cervix, we saw the image back in the obstetrical section, and a motile flagellated organism in saline microscopy. So greenish white discharge with strawberry cervix, trichomonas vaginalis. Curdy white discharge with pseudo hyphae in the KOH mount, sheikh kebab appearance, drug of choices fluconazole, then candidiasis. Then you see the bacterial vaginosis, Gardnerella vaginalis, gray color discharge, clue cell, alkaline pH. You have to remember. Then PID, most common organism is chlamydia overall. For acute PID, gonorrhea is the most common. For virgin female, genital TB is the most common. For IUCD, actinomyces is the most common organism. Overall chlamydia, acute gonorrhea, virgin female genital TB, IUCD, actinomyces. Most common route, ascending infection. Ultrasound, bead of string appearance, or you may see waist sign, or you may see cogwheel sign. Okay, beads of string appearance, or waist sign, or cogwheel sign are the three ultrasound sign you may see it in the PID. Diagnosis, pelvic pain, adnexal tenderness, and cervical motion tenderness is a triad where we use to diagnose the pelvic inflammatory disease. Gold standard is laparoscopy. Treatment is CDC regimen. Treatment is CDC regimen. Genital TB, most common site is ampulla of fallopian tube. Most common symptom is infertility. Route of spread is hematogenous. Investigation of choices, hysteroscopy. Investigation of choices, hysteroscopy. Okay. Then you have endometriosis. Most common site is ovary, where you may see the triad of symptoms of infertility, dysmenorrhea, and adnexal mass. Infertility, dysmenorrhea, and adnexal mass. Investigation of choices, laparoscopy, where you may see the chocolate cyst or powder burn appearance or gunshot appearance. Chocolate cyst, powder burn appearance, or gunshot appearance. Treatment of choices, NSAID plus OCPs. Treatment of choices, NSAID plus OCPs. Then apart from that, fibroids. Speaking about the fibroids, most common type is intramural. Most common type associated with the urinary retention is cervical. Associated with the PPH is submucosal. Most common presentation is asymptomatic. Most common symptom is menorrhagia. Most common degeneration is hyaline degeneration. Broad ligament fibroid, true one is lateral to the ureter, while the pseudo one is medial to the ureter. Treatment of choice, asymptomatic, expectant management, symptomatic, hysteroscopic, myomectomy along with the medical management. Hysteroscopic myomectomy along with the medical management. All of these are important one-liner. Most common type is intramural. Associated with the urinary retention is cervical. Associated with the PPH is submucosal. Presentation most common is asymptomatic. Most common symptom is menorrhagia. Most common degeneration is hyaline degeneration. Broad ligament true is lateral to the ureter. Pseudo is medial to the ureter. Asymptomatic, expectant management. Symptomatic hysteroscopic myomectomy or medical management. Apart from that, urinary fistula, dripping of urine with the urination, uretrovesicular fistula, where immediate repair is there, and dripping of urine without urination, vesicovaginal fistula, investigation is cystoscopy. Best method to collect urine is suprapubic catheterization. And ureteric fistula, most common site is 2 centimeter lateral to internal ovarian sphincter, and the most common cause is simple hysterectomy or TAH, total abdominal hysterectomy. Okay, now surgical repair for obstructed labor with the urinary fistula after 6 weeks. For surgery less than 24 hours, immediate repair. More than 24 hours, wait and watch. And radiotherapy, wait for 12 months. Patient is on radiotherapy, then you have to wait for 12 months to do the fistula repair. Then apart from that, infertility, single best predictor for semen analysis is sperm morphology. Fecundability, conceive in 1 cycle. Fecundity, to give a live birth in 1 cycle. Best indicator of ovarian reserve is your anti-Mullerian hormone. For male, no semen, aspermia. Sperm concentration less than 15 million per ml, oligospermia. Sperm concentration less than 5 million per ml, severe oligospermia. Non-motile sperm, asthenospermia. Sperm with abnormal morphology, teratospermia. Dead sperm, necrosospermia. No sperms, azoospermia. Increase in WBC in sperm, leukocytospermia. Okay, leukocytospermia. Sperm concentration less than 15 million per ml. Oligospermia, 10 to 15 means you have to do intrauterine insemination, 5 to 15 IVF, less than 5 ICSI, non-motile ICSI, and no sperm ICSI is the treatment of choice. Okay, for female, it could be ovarian cause, HPO failure or dysfunction, or maybe due to the premature ovarian failure. If it is a HPO axis failure, then it is Kallmann syndrome. Dysfunction, then it is due to the either increased prolactin or PCOS. This is the ovarian cause, people. Then tubal cause, either endometriosis or inflammatory disease or salpingitis or TB. Okay, or TB. Investigation of choices, hysterosalpingography with Leach-Wilkinson cannula. Okay, hysterosalpingography with Leach-Wilkinson cannula is a investigation of choice to rule out the tubal cause of your female infertility. Then cervical cause, thick cervical mucus or impermeable mucus or anti-sperm antibody is positive. Unexplained cause, treatment is clomiphene citrate. Clomiphene citrate, if it fails, then IVF is a choice. IVF is a choice. Then the last portion is your cancer gynae. Endometrial carcinoma, most common cause in developed countries. Irregular vaginal bleed. Premalignant lesion is endometrial hyperplasia complex with atypia. Premalignant lesion is endometrial hyperplasia complex type with atypia. Very, 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 very important MCQ. Which one is having a more malignancy risk? Hyperplasia complex with atypia. Most common variety is adenocarcinoma. And for endometrial carcinoma, we have a FIGO staging. 1A, confined to uterus with less than half of your myometrial thickness. 1B, more than half. Treatment of choices, Wharton hysterectomy. Okay. FIGO class 2, cervical stroma, but not beyond the uterus. And 3A, uterine serosal involvement. 3B, vaginal involvement. 3C, C1 is pelvic involvement and C2 is para-aortic involvement. And the treatment of choices, surgery plus radiotherapy plus chemotherapy. And the stage 4A is bladder or bowel involvement. And the stage 4B is distant metastasis, where you do only the palliative care. So endometrial carcinoma, most common in developed countries. Irregular vaginal bleed. Premalignant lesion is complex with the atypia. Most common variety is adenocarcinoma, stage 1, confined to uterus with less than half of myometrial thickness. Stage 2, more than half. 1B, more than half. Stage 2, along with the cervical mucosa, but not beyond the uterus. And stage 3A, uterine involvement. Stage 3B, vaginal involvement. Stage 3, C1 pelvic involvement and C2 para-aortic involvement. And stage 4A, bladder or bowel mucosal involvement, and stage 4B is distance. So stage 4 is palliative, 3 is surgery plus radiative plus chemotherapy, 2 is surgery plus radiotherapy, while 1 is Warthin hysterectomy you have to do. Warthin's hysterectomy you have to do. Then cervical associated with the papilloma virus, the one which causes genital warts is 6 and 11, cancer cervix is 6, 11, 16 and 18, where the vaccines are Cervarix and Gardasil. Cervarix and Gardasil. Cervarix covers 6 and 11, while Gardasil covers 6, 11, 16 and 18. Very, 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 very important MCQ. Before 2 MCI, they had asked this as a question. You have to remember that. Then cervical smears, pap smear is a screening test. We can able to see that the CAN, class 1 is less than half of your abnormal, class 2 is 1/3 to 2/3, class 3 is more than 2/3 abnormal cells. Where apart from that, you may do the colposcopy to rule out the carcinoma. Stage FIGO staging, again 1 confined to cervix, 1A is invasive with the depth of less than 5, and 1B is invasive with more than 5 depth of more than 5, while 1B1 is more than 5 to 2, 1B2 is 2 to 4, while 1B3 is more than 4. And stage 2, beyond uterus but not extend to lower 1/3 of vagina, 2A1 less than 4, 2A2 more than 4. And 3, pelvic or para-aortic lymph node plus lower third of vagina plus pelvic wall involvement. Okay, then you have a distance met. Then you have a distance metastasis. Apart from that, ovarian carcinoma, epithelial carcinoma, most common malignant is serous variety. FIGO staging 1A is 1 ovary, 1B is 2 ovaries, 1C is C1, surgical spill, C2, capsule rupture, C3 is malignant cell. C3 is malignant cell, while 2 ovaries along with the pelvic extension. 2A is fallopian tube and 2B is other pelvic organ. 3 is a peritoneal spread and 4 is a distant metastasis. 4 is a distant metastasis. Then apart from that, you have a germ cell tumor. Very, 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 very important is this germ cell tumor. Another one table you have to see while sitting on the exam. Very, 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 very important. Okay. Dermoid cyst is the most common ovarian one. Yolk sac tumor, increase in AFP and Schiller dual bodies. Yolk sac tumor, increase in AFP and Schiller dual bodies. Dysgerminoma, increase in LDH, increased placental alkaline phosphatase, most common germ cell malignant. Most common germ cell malignant is dysgerminoma. Granulosa cell tumor, Karl Exner, inhibin is a tumor marker. Inhibin is a tumor marker. And Brenner tumor, Walther cell nest will be there. Walther cell nest is seen in Brenner's tumor. Karl Exner bodies is seen in granulosa cell tumor. And apart from that, placental alkaline phosphatase is seen in dysgerminoma. And apart from that, Schiller dual bodies is seen in yolk sac tumor. Tumor markers, AFP, yolk sac tumor, LDH, dysgerminoma, inhibin, granulosa cell tumor. Inhibin, granulosa cell tumor. Apart from that, male and female analog, genital tubercle, glans penis and clitoris. From genital tubercle, you have a corpora cavernosum in male, which is analogous to vestibular bulb in female. While urogenital sinus gives rise to Cooper and prostate gland in males, while Cooper gland is equivalent to Bartholin's gland in female, while prostate is analogous to Skeen's gland in female. Apart from that, urogenital fold, ventral shaft of penis in male, while labia minora in female. And labioscrotal swelling, scrotum in male, labia majora in female. The scrotum analogous in the female analogous was asked several times in FMGE. Again, important table, 7-star rated table. Okay. Then epithelial lining, vagina, stratified squamous, exocervix squamous, endocervix columnar, uterus columnar, Bartholin gland, single layered columnar, Bartholin duct, multilayered columnar, fallopian tube, multilayered ciliated columnar. And apart from that, the ligament which does not support uterus is your broad ligament. The ligament which do not support uterus is your broad ligament. So these are the important one. Apart from that, you have important things here. So one is your lambda sign, where you see the dichorionic diamniotic twins, and monochorionic pregnancy. You may see the T sign. You may see the T sign here, and here you may see the lambda sign, and here you may see the lambda sign, and here you may see the T sign for a monochorionic pregnancy. Apart from that, some important obstetrical forceps was there. Tucker's McLean was there, Simpson forceps, Elliott forceps, Kayland forceps, Piper forceps, Bailey Williamson forceps are there. These are the important one you have to remember in terms of your forceps. This is the lateral side and this is the anterior side. And this is the anterior side, quite an important one where you should not forget. So with this, we are completing our obstetrics and gynecology. So here, what are the important things I want you to remember in PDFs. So mark important things in the PDF so that you cannot able to miss it. Okay. So let me put you up here. So speaking about that, so important highlights are size of the sperm is 55 micron and duration is 72 to 74 days. And one spermatogonia, 16 primary, and one spermatocyte, which is 4 sperms. So one spermatogonia, which gives rise to 64 sperms. Ion responsible for sperm motility is calcium. Gene is Caspar gene. And the gene which is responsible for fertilization is fertilin gene. Location is ampulla of fallopian tube. And implantation, most common site is posterior surface of upper uterine segment. Upper uterine segment. Apart from that, you have this like the placenta. Among the placenta, the important one is the placental weight equals the mother's weight by 17th week of gestation. Attachment is on the upper part of your uterine wall, posterior part especially. And apart from that, tertiary villi forms by day 17. Hormones and their location, syncytial trophoblast is the location of your hormone, and progesterone, estrogen, HPL, and HCG. HCG T off is 24 to 36 hours. Missed period is 100 international units per liter. Maximum in 17 days, minimum in 16 days, disappears 48 hours after the delivery in urine. Okay. Velamentous type of your umbilical cord attachment is splitting of vessels prior to the insertion. Oligohydramnios less than 200 ml at term or AFI less than 5. Polyhydramnios more than 2 liters at term or more than AFI of more than 25 centimeter. Major contributor in the third trimester is fetal urine. And golden yellow amniotic fluid is seen in RH incompatibility, while tobacco juice is seen in intrauterine death. Tobacco juice is seen in intrauterine death. Then all the sign, Hagar sign and Goodell sign. Hagar sign is the lower portion of the uterus softening, while your Goodell sign is a softening of cervix. And apart from that, you have the after softening of uterus after 6 weeks is Laden, and Oslander is your like an increased pulse in the lateral fornix. Chadwick blue is discoloration on your vaginal mucosa. And apart from that, Palmer sign, which is a regular rhythmic contraction of the uterus at the bimanual examination. Smoking causes IUGR. Pregnancy is a hypercoagulable, hyperestrogenic state with respiratory alkalosis with compensated metabolic acidosis, and and pregnancy is also a pre-diabetic stage. And apart from that, cardiac output increases, factor 11 and 13 decreases, and you see there is a decrease in the FRC, ERV, RV, TLC, and PCO2. Menger syndrome or supine hypotension syndrome is compression of IVC on the supine position. Treatment, turning the patient to the lateral side. Most common female pelvis is gynecoid. Most common male pelvis is android. Deep transverse arrest is seen in android. Face to pubes delivery is seen in anthropoid. And you may see the C-section or asynctylism in the platyploid. See, one absence of ala of your sacrum, then the pelvis is Naegele's pelvis. Two ala of sacrums are absent, then it is Robert pelvis. And submento-bregmatic, you may see the face presentation. What are the normal uterine contraction? 3 contraction in 10 minutes, each lasting for 45 seconds over 220 Montevideo unit. Stage 1, onset of labor to cervical dilatation. Stage 2, the cervical dilatation to expulsion of fetus. Stage 3, expulsion of fetus to your placenta. Stage 4, observatory period. Stage 4, observatory period. Cardinal movement, every decent female I choose to employ rises exponentially. You studied that. Apart from that, PPH, most common cause of primary is atonic, secondary is retained placenta. Secondary is retained placenta. Obstetrical normal obstetrical shock index is 0.7 to 0.1. Sorry, 0.07 to 0.8. Uterine inversion, shock immediately after delivery, where you use a Johnson's maneuver for manual replacement, and vaginal surgery are Spinelli and Kushner method. Abdominal surgery are Huntington, Robinson, and Halton method. Huntington, Robinson, and Halton method. Apart from that, placenta accreta, most attachment at superficial myometrium, increta, deep percreta, myometrium with the serosal involvement. Okay, completed family, then do the C-section and hysterectomy, while incomplete family do the conservative management. And apart from that, amniotic fluid embolism, very, very rare. Sudden onset of collapse plus DIC plus altered mental state is amniotic fluid embolism. Criteria, acute hypotension or cardiac arrest, acute hypoxia, coagulopathy. Mostly patient dies where you see the postmortem finding as amniotic fluid and pulmonary vessel. Pulmonary vessel. Apart from that, you may see the induction of labor where you see the Bishop score. I used to remember with the mnemonic of Deepak cervix with head station. D stands for cervical dilatation, P stands for position, E stands for effacement, C stands for consistency, along with the head station. In a modified Bishop score, effacement is replaced by cervical length. Effacement is replaced by cervical length. Pressure on the cervix will produce the contraction of uteruses, Ferguson reflex. Malpresentation, most common position, malposition is OPP, seen in android and anthropoid pelvis. Okay, DTA, you can able to manual rotate the head using a Kalen forceps. Oblique posterior, face to pubes delivery. Deep sacral, C-section is the management. Apart from that malpresentation, for a face presentation, most common causes anencephaly, most common pelvis is platyploid. Most common pelvis is platyploid. And a breech presentation where you may see that there is a longitudinal lie along with the breech presentation. Buttock, the engaging diameter is bitrochanteric, where you use a pinard maneuver. For shoulders, Lawset maneuver. After coming head, you see the forceps delivery or Marshall-Smelke Yelt technique or Bracht maneuver or Bern-Marshall technique, or you may see the Weigen-Martic technique. Then apart from that, you may see the unstable lie. Most common cause of fetal death in unstable lie is cord prolapse. Most common cause of transverse lie is prematurity. And forceps delivery. Outlet forceps used in India is Wrigley's. Mid-cavity forceps in India is Das or Neville's. To rotate the fetal head, Kayland or Barton. Delivery of aftercoming head is Piper's forceps. Most common complication is perineal tear. And apart from that, maximum attempt is 3. For a vacuum delivery, attempt is 3. Location is 3 centimeter anterior to posterior fontanelle or 6 centimeter posterior to anterior fontanelle. Episiotomy, most common one are median and mediolateral. Ideal time before the crowning. Ideal time is before the crowning. C-section, type of incision, Fennelstein and Joel Cohen. Absolute indication was CPD, broad ligament fibroid, central placenta previa, cancer cervix, and vaginal atresia. Level of anesthesia T4. Uterine rupture is seen in USCS, and ideal waiting time is 18 months. Minimal waiting time is 6 months. Okay, ectopic pregnancy. So any state of having implantation other than the normal site. Amenorrhea, lack of doubling of BCG, adnexal mass, extrauterine pregnancy detected. Treatment of choices, exploratory laparoscopy for ruptured, for unruptured, exploratory laparotomy for ruptured, for unruptured, exploratory laparoscopy. Abortion, termination before 20 weeks. As per the WHO, termination with the baby of less than 500 grams. Most common cause, chromosomal anomaly, especially aneuploidy. Most common trisomy 16. Threatened abortion, retroplacental hemorrhage will be there. Recurrent abortion, most common cause of second trimester recurrent abortion is cervical incompetency, incomplete, where you see the passage of fetus of consumption, complete empty uterus, missed dirty brown discharge, septic, foul-smelling discharge, or purulent vaginal discharge. Okay, apart from that, you have a best method, medical termination less than 7, suction and evacuation 7 to 12. Okay, then you have a placenta previa. Most dangerous type is type 2 posterior. Regimen we use as McAfee and Johnson regimen. Then you have a diseases. Most common system involved in CVS. Congenital anomaly is VSD. Most specific one is caudal regression syndrome. Most specific cardiac is transposition of great vessels. Okay, then you have a fetal complication. One of the classical one is macrosomia. Stage of labor to be reduced in pregnancy with the heart disease is second stage. Most common lesion is mitral stenosis. Most common heart disease is rheumatic heart disease. Most common heart disease is rheumatic heart disease. Apart from that, LH surge occurs 24 to 36 hours prior to ovulation. Day of ovulation is cycle days minus 14. Abdominal pain during ovulation is here, Mittel-Schemers syndrome. And apart from that, you have this primary amenorrhea, UPT negative, secondary sexual characteristic normal, uterus is there, then anatomical malfunction, then that is due to cervical atresia, transverse vaginal sputum, or imperforate hymen. Negative MRKH syndrome. Or if there is no secondary sexual characteristics, then look for the FSH and the LH. Decreased Kallmann syndrome, increased primary ovarian failure, Turner, and galactosemia. Then secondary amenorrhea, most common cause is pregnancy. Improper periods is seen in PCOD. No periods is seen in Asherman, Sheehan, and primary ovarian failure. Abnormal uterine bleeding, polymenorrhea, less than 21 days. Oligomenorrhea, more than 35 days. Hypomenorrhea, less than 2 days of bleeding. Menorrhagia, more than 7 days of bleeding. Menometrorrhagia, abnormal bleeding at irregular intervals. Abnormal bleeding at irregular intervals. Surgical management is endometrial ablation, while medical management, variety of causes will be there. And menopause, premature, less than 40, delayed, more than 55. Lack of estrogen, osteoprotein protein impairment, Rankel ligand activation, osteoporosis will be there. Heart flashes will be there. Wrinkling of skin will be there. HRT will be there. HRT will be the treatment of choice. Postmenopausal bleeding, most common causes endometrial atrophy. Gold standard is fractional curettage plus hysteroscopy. Puberty, precocious puberty, male less than 9, female less than 8. Delayed puberty, non-development of secondary sexual character in females, less than 13, male less than 12. Okay, McCune-Albright syndrome, triad, Cafe-Ollet spot, precocious puberty, polyostotic fibrous dysplasia. Okay, then you have this infection, greenish yellow discharge, and motile flagellated organism in saline microscopy with the strawberry cervix, Trichomonas vaginalis. Curdy white, pseudohyphae, chic kebab appearance, candidiasis. Gray color, clue cell, alkaline pH, bacterial vaginosis. Most common cause of PID, chlamydia. Acute gonorrhea, IUCD, actinomyces. Virgin female, genital TB. Most common route of spread is ascending infection. And USG show bead of string appearance, waist sign, and cogwheel sign. Gold standard in laparoscopy. Treatment is CDC regimen. Genital TB, most common site is ampulla of fallopian tube. Most common symptom is infertility. Route of spread is hematogenous. Investigation of choices, hysteroscopy. Then fibroids, most common type is intramural. Urinary retention is cervical. PPH is submucosal. Most common symptom is menorrhagia. And most common degeneration is hyaline degeneration. Okay, most common site of your ureteric fistula is 2 centimeter lateral to internal ovarian sphincter. Most common causes simple hysterectomy or total abdominal hysterectomy. Investigation of choices, cystoscopy. Then no semen, aspermia, sperm concentration less than 15, oligo, less than 5, severe oligo, no motile, asthenospermia, sperm with abnormal morphology, teratospermia, dead sperm, necrospermia, no sperm in semen, azoospermia, increased WBC, leukocytospermia. Okay. Apart from that, unexplained cause, clomiphene citrate you can give. And apart from that, your female infertility would be ovarian or tubal or cervical. So tubal cause, in order to rule out the tubal cause, you have to do the hysterosalpingography with Leach-Wilkinson cannula. Leach-Wilkinson cannula. Most common remalignant lesion is endometrial hyperplasia, complex type with atypia. Complex type with atypia. Cervical carcinoma associated HPV is 6, 11, 16, and 18. While genital warts, it is 6 and 11, which is treated by Cervarix, and 6, 11, 16, and 18 is Gardocell. Screening test is pap smear, where CIN 1 is less than 1/3, 2 is 1/3 to 2/3, while 3 is more than 2/3. While 3 is more than 2/3. Most common type of ovarian carcinoma is epithelial carcinoma. Most common malignant variety is serous, germ cell, yolk sac, tumor marker AFP, dysgerminoma LDH, and granulosa cell tumor inhibition. Carl Exner is seen in granulosa, while placental alkaline phosphate is elevated in dysgerminoma. Schiller dual bodies is seen in yolk sac tumor. Walthat cell nest is seen in Brenner tumor. And female analog of scrotum is your labia majora, prostate is Skeens, Cooper is Bartholin, Corpora cavernosum is vestibular bulb, and glans pin is a clitoris. And a ligament which does not support the uterus is broad ligament. So we have covered most of the important theory and most of the important images. All the images are pretty important. So read out the PDF again and again, people. So all the very, very best. So read the gynae tomorrow. And tomorrow I will see you with the new subject. Tomorrow I will see you with the new subject. Have a nice day. Take a good rest. Have a good night, people. Thank you, everybody.